Good morning, everybody. I would like to welcome you all to the TB Day academic program organized by the Assembly of Mycobacterial Diseases of Sri Lanka College of Pulmonologists. As the first event, I would like to welcome Dr. Ravani Karunathilaka, President, Sri Lanka College of Pulmonologists, to deliver the welcome address.
My dear teachers and colleagues, tuberculosis is probably the most ancient disease to afflict mankind. And evidence of this disease had even been found in the spine of the mummified remains of the Egyptian boy, King Emperor Tutankhamun, who died at the age of 19. Countless famous personalities have suffered from tuberculosis at some point in their lives. For example, Nelson Mandela, Bishop Desmond Tutu, Tina Turner, Franz Chopin, and many others have also died due to TB. Robert Koch, the famous German physician and microbiologist, announced the discovery of Mycobacterium tuberculosis, the causative organism of TB, in the year 1882. Yet, 140 years down the road, the disease still remains the second largest infectious killer across the world. The magnitude of the problem is underestimated in Sri Lanka. TB reports the third leading incidence and the second leading mortality rate amongst infectious diseases in this country, second only to COVID-19. The Sri Lankan government has committed to end TB by the year 2035, which means we need to bring down the incidence of TB to less than 10 per 100,000 population from the current estimates of 64 per 100,000. According to the World Health Organization, there is an estimated 13,500 patients whom we should detect each year. But on an average, the case detection rate has always been around 8,000. And there is a gap of 3,000 to 4,000 patients undetected in the country. Unfortunately, in the year 2020, the number detected had started to drop to 7,000, and further in 2021. And now, our case detection rate is approximately 50% of the estimated cases in the country. This, in fact, is very alarming. A study conducted by the National Program for Tuberculosis and Chest Diseases has shown that there is a mean delay of 4 days in a district chest clinic, 13 days in a government hospital, and close to 1 month delay amongst the private healthcare providers in arriving at a diagnosis in a TB patient. What does this mean? It means we are missing TB because we are not thinking TB. It is important as healthcare workers we remember that though prevention is better than cure in most cases, this does not hold true in the case of TB. Cure is prevention. The more the number of infectious TB patients we diagnose early, treat and permanently cure, less the number of other healthy people infected. Therefore, I think TB should no longer be a diagnosis we suspect when nothing else works, but to be a differential diagnosis at the very earliest. The TB Assembly of the Sri Lanka College of Pulmonologists have put together a well-thought-out academic program with the involvement of undoubtedly the experts in the field to talk to you today. I thank the Assembly, all speakers, and more so Dr. Ishant Pereira and Dr. Vatsala Gunasinghe for their hard work. I conclude by inviting you to recognize the theme of this year's World TB Day, which is Invest in TB to Save Lives. And if we all do so, reaching the goal of end TB by 2035 will be possible for Sri Lanka. Thank you.
Thank you, Madam, for that enlightening welcome. I would like to invite Dr. Bandhu Gunasena, Consultant Respiratory Physician, National Hospital for Respiratory Diseases, Valisara, to chair the morning session. Over to you, sir.
Thank you, Vatsala, for kind invitation. Good morning, everybody. Without going into further details, I would like to start the sessions right now. My present task today to introduce the first speaker. She will be talking about laboratory aspects of TB control. She is the consultant microbiologist at National Children's Hospital, Lady Ridgeway. But she has been a resource person for most of the TB work in Sri Lanka. She has been at National TB Reference Laboratory for a long period, and during her period of office at National TB Reference Laboratory, we introduced most of the new innovative laboratory diagnostic techniques in Sri Lanka. I welcome Dr. Dhammika Vidanagama for her speech.
Yeah, good morning, everyone. Thank you, Dr. Bandhu, for that kind introduction. And thank you, Dr. Ishant and the College of Sri Lanka College of Pulmonologists for inviting us for this talk. I think this is very important to start talking about diagnosis, but I think I will not waste much time to talk about TB. Madam President gave a very good introduction, but we will look at the advances in microbiological diagnosis straight away for TB and the tools we have at the moment. My outline will be why we should diagnose TB and what do we try to diagnose. Is it TB disease or drug resistance in TB, because that is also an important topic for us, and how we should go about in diagnosing TB. There are so many tools you have heard about because it's an ancient disease. We have been using many tools, but which tools we should use and for which purpose, and then how to use it optimally, because all those tools will be expensive to a certain extent. We'll have to choose the best tool for that occasion. So we go for a microbiological diagnosis for the confirmation of TB disease. When we think of TB, first of all, I think the diagnosis of TB will start not in the laboratory, but in your clinical setup. You have to think of TB all the time, invest your thoughts and your energy in TB, and if you take a sample and send to the laboratory only, the microbiological diagnosis will start. So the diagnosis will start in the clinical setup. But when we take bacteriological confirmation, that will be very important to manage your patients. Patient outcome, morbidity, mortality will also depend on that. And then epidemiological tool for prevention, because when you treat and cure the patient, that will be the best tool for prevention, as we are going to discuss in NTB strategy. So we have to confirm disease. You can go for passive case detection. You can wait till the patient comes to your clinic or hospital. But it's a better way to do a systematic screening. WHO is promoting systematic screening. Basically, in high-risk groups, you have to identify the high-risk groups, or sometimes general population in a high TB prevalent country. But at the moment, Sri Lanka doesn't belong in high TB prevalent countries. And we need to detect drug-resistant TB to make sure that your treatment is effective to cure the patient. And then we have to use some diagnostics to investigate the contacts of a TB positive person as a tool for prevention. So always we go for test and treat TB to end TB, invest in TB as a theme for this microbiology, theme for the TB day of the year. So it's an ancient disease, it's a common infection, largely curable and preventive, but still I think for so many years we are fighting with this, still remaining a leading cause of death globally. And in 2018, just before COVID started appearing, UN General Assembly made this pledge to fight against TB. Many people, many world leaders got together and they wanted to diagnose and treat 40 million people by 2022. We have almost come to the second quarter of 2022, and it is a question where we have been all this time. We were thinking about COVID, but we have missed a lot of TB. We have, I think, in 2019, end of that only we started getting COVID. Still we have missed about 30% of cases, and the scenario is even worse, as Madam President mentioned. So diagnosing and treating 40 million people is an ambitious target. We need strategies to improve the diagnosis. So we need, in the NTB strategy, as the first pillar, we have to ensure early diagnosis for all with TB, because early diagnosis will limit the duration during which the patient will be in the society, in the community, spreading TB. So one of the strategies recommended is systematic screening. I emphasize on this because this is not happening at the moment. At least to keep aside systematic training, passive case detection should be improved. So we have many tools. Some of the tools are clinical. There are clinical scoring systems, symptom-based screening that should happen at clinical settings. We have to promote that, but I'm not going to talk about clinical, radiological and immunological tools at the moment. We need the microbiological tools for confirmation and for follow-up of people to see whether they are on the right track for treatment and for drug sensitivity testing. So the work has started on microbiological diagnosis so many years ago, over a century, and that won a Nobel Prize in 1905 to this famous microbiologist. We are commemorating World TB Day on 24th March because of that. So many more test methods followed: microscopy, culture-based methods, direct diagnostics, molecular ones. But many people are still suffering with TB and they go undetected, they spread TB, and finally some of them succumb to TB. A considerable number of deaths will be there. So we have many tools. We have microscopy, which is a primary tool, which I think is the backbone of TB, which had been used for a long time. We should not forget about it. But we know the limitations. It detects, it needs a lot of bacteria in a sputum sample, nearly 5,000 to 10,000 bacteria in 1 milliliter to detect that. And WHO recommends replacing microscopy as the first diagnostic tool, which we have to do very, very carefully with the availability of other techniques. And next, the TB culture. It is still considered as a gold standard, but there are many limitations. It's not the perfect choice, but it's better than microscopy, but it's technically demanding, more costly, and it takes more time and needs more facilities to control the infection within the laboratory. And then we have to think about conventional microscopy, which is the primary diagnostic tool. We see these acid-fast bacilli in sputum smear, Ziehl-Neelsen stain, which we have been using for over a century. But advances are there in fluorescent microscopy, which helps to screen disease and detect more quickly when these microscopes are available. I think these microscopes are distributed to many of the chest clinics to use it for high TB detection settings. It will facilitate the detection without much eye strain, and these LED type microscopes with fluorescent lighting available at some of the chest clinics to improve the diagnosis of TB with sputum microscopy with Oramine stain. And advantages will be it can be done at any setting because a microscope is available in most of the laboratories in the country. Almost all TB clinics and microscopy centers in all the small hospitals and clinics, they have a microscope. They have trained technicians. They can perform microscopy. It's available at the grassroots level. And it is accessible to majority of patients, and it is useful in monitoring the success of your anti-TB treatment. So we have to make the maximum use of microscopy as the backbone of our diagnosis. We should not forget about microscopy. And then comes the culture, mycobacterial culture. As we know, these mycobacteria do not grow at a very fast rate. They don't grow at a rate that we would like them to grow. It takes time, slow growing bacteria. So we use it as a reference standard. Rather than calling a gold standard, it's not the ideal technique, but we have it as a reference standard. It's more expensive and time consuming. You will have to wait for weeks to see your result, but it is definitely more sensitive than microscopy. It can grow even a few bacteria present in ml of sputum or whatever your paucibacillary extrapulmonary sample, it can grow. We can use egg-based media or liquid media for this. So liquid medium helps the organisms to grow quickly because it has enrichment and some antibiotics to suppress the growth of other contaminants. So liquid media are the preferred choice, but that will be more expensive. And for so many years, I think, over decades, the Sri Lankan network of TB diagnostics, they use the LJ medium, Lowenstein medium with egg-based medium to grow TB. That is also successful and it is less costly. And when we grow it on the medium, we have to diagnose it because many other organisms also can grow in cultures. We have to identify it as TB using acid-fast nature of the organisms, like shown in this picture, liquid medium, AFB, you have to visualize. And then there are other techniques like MPT64, typical antigen in TB bacilli, which we can use to confirm the identification. Because anything that grows on this media is not TB, we have to identify and confirm. And we have this technique in National Reference Laboratory, the automated liquid culture systems, which is the reference standard at the moment. It is closer to a gold standard because it grows organisms more quickly than the LJ-based media. It is on commercially available consumables, culture bottles with a liquid medium and some antibiotics and growth supplements to support the growth. And it is inoculated into this bottle, the tube, and put into a machine, and machine will monitor the growth of organisms. So this is important as a reference laboratory to use this, and some of the regional laboratories also should be using this technique, and this can be used for the drug susceptibility testing also. So for drug susceptibility, we use the culture-based methods. We have to first grow the organism, and then there are several methods to do this drug sensitivity testing, not like the normal ABST we use in the microbiology laboratory. This is a more tedious, more sophisticated procedure, but this is available for so many decades now at the National TB Reference Laboratory at Velisara. And we use the proportion method there, mainly on solid medium, but recently liquid media based ABST also started there. But molecular methods are there. Those are quicker and we will discuss those later. So these culture-based DSTs on liquid or solid media are recommended by WHO, but they are time-consuming due to slow growth, technically demanding. You need biosafety level 3 laboratories, and then we need some reliable methods. For some of the drugs that we use, for the first line treatment or the second line treatment, there are no reliable methods using this technique. So some of the treatment decisions we might not make based on that. That is one of the limitations. But for baseline antibiotics like rifampicin, INH, there are very good methods which we can rely for the patient management. And culture-based phenotypic DST, we can use on newer drugs like bedaquiline. There are reliable methods, and whereas there are no reliable genotypic methods, there are some phenotypic methods which can be useful. Finally, we come to the most interesting part of this, the molecular diagnostics. Nowadays, everything is going for a molecular diagnostic platform. So, detection of genetic targets to see whether there are MTB specific genes in your specimen, or sometimes you can look for the mutations conferring drug resistance directly on this. So the applications will be direct detection of TB and confirmation of diagnosis, and then You can use it on culture identification also. When you have grown something on your liquid culture or LJ medium, you can use it to confirm that it is TB, not some other mycobacteria. And then you can use it for drug resistance detection and sometimes used for epidemiological studies for typing as well. These molecular diagnostic methods, sometimes there have been conventional PCR platforms we have been using, but more and more rapid PCR methods are coming into WHO recommendations. There are rapid cartridge-based or commercial chip-based methods which are called cartridge-based nucleic acid amplification tests, and sometimes other techniques like loop-mediated amplification and sequencing methods. Those are some of the methods that are available globally, but in Sri Lanka we have basically these rapid cartridge-based methods all over the country. There are about 31 machines to my knowledge all over the country, available from Jaffna to the southern corner, Matara, Hambantota, and then from east to the many machines available in the western province. We have a lot of machines available for the rapid diagnosis. So we can go for a rapid molecular diagnosis of TB and drug resistance, mainly the rifampicin resistance, in a few hours. Using these genotypic methods, targeted genes are detected to confirm that it is TB. So those are called molecular techniques recommended by WHO. So those are globally used. We call it in short MWRDs. So WRDs, we have expert test, gene expert test. I think most of doctors are now aware of the name of gene expert. And then there are other tests called loop mediated amplification, TrueNet TB, and line probe assays. Of these 1 to 4 numbers, 1 and 4 have been available at least for nearly 10 years now in Sri Lanka. From 2014 we have been using gene expert and line probe assays for the diagnosis of TB and drug resistant TB in the country. So these are the platforms available for users. This platform for diagnosis of TB and simultaneous detection of drug resistant TB. There are WHO recommendations for using this expert technique as the initial diagnostic test. Without going for microscopy, in some populations we can go for gene expert test easily to diagnose TB as well as the presence of resistance to rifampicin. Fortunately in Sri Lanka, rifampicin resistance or multi-drug resistant TB is not a major problem, but it is worthwhile diagnosing, and especially for the diagnosis of TB meningitis, it had been very useful and it had been life-saving. So extrapulmonary TB also, this expert is recommended in adults and children with signs and symptoms of EPTB, both for diagnosis and rifampicin resistance detection. So these are WHO recommendations. I'm not going to discuss in detail, but this has been a well-established test for over a decade in the country, and recently I think it had been recommended for a conditional use on blood also in immunosuppressed patients and fecal samples in children. And there's this ultra-assay which better sensitivity, and it has uses the same platform and a different cartridge. But we come into issues because of this high sensitivity. There may be very limited small quantities of DNA used. So we have to use it very, very carefully with clinical interpretation, especially when it comes to patients who had diagnosed TB or treated TB earlier. We have to be very careful when we are using this. So I think you need expert advice from laboratory as well as clinical specialists when you are using this assay in the country. So there are many WHO recommendations for expert ultra test, but I would like to use a word of caution when we are using it, because there can be trace calls detecting very minute quantities of DNA, TB DNA, and that will give sometimes indeterminate results in rifampicin resistance. You have to use it very, very carefully. always seek expert advice when you are using this. And then there is this other technique for detection of XDR, extensive drug resistant TB. This is useful for RRTB, MDR-TB patients to see whether they are susceptible to the drugs used for second line treatment. So this is not yet recognized by WHO, but it is available as expert MDR, TB-XDR cartridge used in the same platform. And the TrueNet PCR is a new thing. These machines are available, I think, in the country. People are using this for COVID PCR. So this is recommended, lot of recommendations, but I think in Sri Lanka, since we already used expert TB for decades, now I think it may not be very useful to move away from that. But we have to use TB microscopy and LJ culture. We have to remain, those need to remain as the backbone if it happens, because all these reagents are going to come from overseas. We are not making any of the things in the country. And we have the TB lamp assay. This is again a PCR which can be used in low facility settings, but it does not detect resistance to anti-TB drugs. So there's no advantage here other than for a small cost advantage. So there are many WHO recommendations on this TB lamp. It may be used as a replacement test, but in the country I think we still have a very strong facility for TB microscopy and expert assay as the first line molecular test. But WHO has nevertheless recommended for different settings this technique. And the next technique available in Sri Lanka is a line probe assay. So those are DNA, again a PCR based test. It is a DNA strip based test. It will detect presence of TB in a sputum sample or in a culture growth, and it will detect the susceptibility or resistance to INH and rifampicin both. So that can be used for the MDR-TB diagnosis with the presence of mutation probes present here. So it's like a normal PCR. You go for a DNA extraction, amplification, and then for a hybridization. It's actually a reverse hybridization. There are strips with different targets on this DNA strip, and your amplicon will bind onto these strips, and you can go for a reading like this. There are internal controls here, so those need to be there. And then with the presence of mutation probes or with the absence of some normal wild type probes, you can detect the presence of drug resistance here. It's again a commercial based assay which is recommended by WHO. We can use for TB detection of sensitivity to first line drugs as well as second line drugs. This test is available in the National TB Reference Laboratory, Sri Lanka at Valisara for the last few years. So it will detect second line one, fluoroquinolone resistance, and aminoglycoside and cyclic peptide resistance can be detected. And this interpretation is very complicated, so it has to be done at a reference laboratory. And other assays, like I would like to talk about one thing, urine. This is the non-molecular method, but a rapid method detecting lipoarabinomannan. It's a MTB specific antigen which is excreted in urine. It is used for very few indications, actually. Restricted test. It cannot be used as in the same way that you use microscopy. It is restricted for HIV positive individuals with WHO recommendation for very specific, even for HIV patients. You can't use it on all HIV patients. They have specified which patients to test in outpatient settings and which patients to test in inpatient settings, and to how to go by CD4 cell counts, and all those are very specific. At the moment we don't have the test, but in case if we use, we have to use it again very carefully for limited populations, using this WHO recommendation very carefully to select our patient population to be tested. There are so many other tests that have been used. Some of these details are for growth based tests. There is this microscopic observation of drug susceptibility and nitrate reductase. There are so many different tests. I'm just listing out, but I don't think a country needs all these tests to be established. We will need to select very few tests based on our epidemiology and then establish those and use those things in a very cost effective manner. And there are several tests like big real time high throughput PCR systems. Some of these have been approved by the Global Fund, but there's no WHO recommendation. And there is another interesting thing, this line probe assay for pyrazinamide resistance, that is also pending WHO approval, may be useful in few cases. So this is not for everyone. And then next generation sequencing, I think most of you would have heard about. This also can be used in some patients. So all those tests, among those, there are tests not recommended also. So when you are selecting tests, you have to think about the sensitivity. So there's no major difference in sensitivity in many of the tests that we have. It's all nothing close to Expert Ultra has a higher sensitivity. Apart from that, it 80%, 78% like sensitivity. So that's why we know that there's no single tool that will fulfill all your needs. We need diagnostic algorithms, and we have to think about many factors when you are using a new test in a setup. So this NTB strategy, we need to diagnose TB, do DST, and treat your patient appropriately. And availability of universal DST, I think we have all the facilities here. So we have to think of TB, test for TB, and treat TB, finally to reach the targets of NTB strategy. Thank you.
Thank you, Dr. Vidanagama, for very informative lecture. Are we having any time for questions, or we will go for the next? Sure.
And for highlighting the importance of taking things in clinical context and local context, Mike, do you have any data on the sensitivity of Ultra and Expert on in CSF locally?
No, I don't think we have analyzed. We have used in some instances, but always when you get a trace call, you have to be very, very careful. Even with Expert, the normal assay, MTB RIF assay, with CSF samples, we get always very low quantities.
Low?
Very low quantities, quantity-wise, because it's all paucibacillary. So very low quantities.
When you say quantity, you mean the CSF volumes, or is it volume?
No. About the quantity of
bacillary load.
Bacillary load is low. There's paucibacillary sample, the CSF sample. So usually when you get for TB on Expert, you get a semi-quantification there, high, low.
Yes.
So it's most of the time it's very low.
What kind? Is there a specific CSF volume that you think that we should be sending for Expert alone or Ultra?
Yeah, this has been specified, but considering the nature of urgency of disease diagnosis, they have allowed very low quantities also. Even 0.1 ml we can test, but only thing is we can't exclude. So this, though we use it, the sensitivity on CSF is very low. Now what we have shown is 70%, 80% sensitivity is on sputum. But for CSF it's low. So it's not a test to exclude TB.
Yes.
It is to include. So even the Ultra call, I think Ultra test when you use, if you get a trace amount, you have to use a lot of clinical and laboratory knowledge, other tests to confirm that. Because you have to discuss the patient's contact history and then past history, past treatment history, and all those things you might have to use. But it is very important to use Ultra is recommended actually.
Yeah, literature suggests about 90% sensitivity.
It is sensitive, but when a test is very sensitive,
yes,
in a low prevalence setting, you have to always interpret it very carefully, because this happened to us with the drug resistance survey.
Right.
Some of the resistant cases that we detected were non-synonymous, like they were silent mutations. So when a very low percentage of a target is there, with a very highly sensitive test, you always need multiple factors to interpret this test result.
does centrifugation and things add to the sensitivity, like in smears in CSF?
Yes, you can do it on a deposit, but
in terms of gene expert and PC.
It does. You can do gene expert on a deposit sample. Or usually when we get a sample, we process it with the decontamination and all those things, and then get a deposit. You can use that deposit for gene expert as well. That will increase the sensitivity, but again it will not be 100%. But Ultra obviously has recommended for children and for meningitis. Right. Okay. Thank you.
Okay.
Dhammika.
Thank you very much, Dr. Vidanagama. I have to hand over the certificate. Please stay for a second. Another announcement for our online viewers. Whenever you have questions, you can put those questions in Q&A. My next task is to invite our next speaker. She will be speaking on, talking on tuberculosis in children, a difficult conundrum. It's my pleasure to invite Dr. Ridma Jayaratna, who is a consultant pediatric pulmonologist attached to University of Sri Jayawardhanapura. Ridma, over to you.
Thank you, sir, for your kind introduction. Good morning, everyone. My dear teachers and my friends. So today my task is to discuss about tuberculosis in children. So we'll see why it is difficult. So during next 25 minutes, I'll be trying to discuss why the pediatric tuberculosis is important among the adult patients, and also why it becomes difficult in the clinical situation, and is there any contribution that we can do to minimize the pediatric TB burden, and also to end TB at the end. So pediatric TB is unique disease. So it is postbacillary, but it will leads to a devastating outcomes among the children, and it will give a large burden to the families as well. So it often does not follow rules as the usual nature of the kids in the clinical presentation, and also it is often challenging to the physicians in coming into the conclusions of the diagnosis of TB. Early identification or the diagnosis and the prompt commencement of treatment is vital to prevent childhood mortality. So we'll see why pediatric TB, how it comes from. So going back to the history, so pediatric tuberculosis also being discussed more than 5,500 years ago, and in recent history, about a century ago, Anton Gahn discussed about the pediatric tuberculosis presenting with mediastinal adenopathy, which was demonstrated in post-mortem samples, and the Parrott also discussed the clinical correlations of this pathological specimen. So that's how it progressed. And if you look at the disease burden worldwide, so as our Madam President mentioned, so it estimates more than 100 millions of TB cases all around the world. And most important fact here is 10% of this global burden coming from ill children with the tuberculosis. And most importantly, if you look at the breakdown, so 40% of this disease burden among pediatric TB come from Southeast Asia. So we have a huge responsibility in identification of pediatric TB, and then from treatment to minimize this mortality due to the pediatric tuberculosis. So far, so good. So if you look at the highlighted area, here is the Sri Lanka. Still, we lie in the lower mortality rates for the children. But as Madam mentioned earlier, so if you look at the Sri Lankan data, so we detect only about 3% of the real burden, which is expected to be 5 to 8% according to the WHO estimation. So it is important to identify these children to fight against TB. The other important fact when you talk about the pediatric TB is the current dual epidemic with the retroviral infection. So if you take a child with TB infection compared to a child with retroviral infection and TB, so they have 20 times greater risk of dying due to TB. So, but having said that, so if you look at the distribution of pediatric TB population, still untreated tuberculosis aged less than 5 years without TB consists a large lot. So we need to detect these children. But as we said at the beginning, it is difficult, it is challenging to diagnose these patients because it is not straightforward clinical presentation. So you have wide range of clinical presentations. There may be associated immune deficiencies that makes the diagnosis more difficult, and sample collection is very much difficult. And then when we interpret the test results, especially the radiological investigations and the bacteriological investigations, we have dilemmas, and then we have special situations like in perinatal TB that we need to consider. So if we think about the range of clinical presentation among children, so we do have typical adult type presentations where you have fever, cough for more than 2 weeks, maybe adenopathies, wheeze or weight loss, and with the presence of contact history. But most often this is not the case. So there are a lot of unusual presentations, but those are common. So when a child coming with poorly resolving pneumonia, even after giving appropriate doses of antibiotics and appropriate duration, if symptoms are not resolving, or the complicated pneumonia, and then especially when there's pleural or pericardial effusions, and maybe complicated CNS infections, cranial nerve palsies, when a child with immune deficiency coming with these milder symptoms, and when there's multisystemic involvement. It's not the lung always. So in children, most often we see the disseminated disease, so multisystem involvement. And especially when you're handling children coming from immigrant populations and displaced populations, thinking of pediatric TB is quite important. As Madam President mentioned, so it should not be the last resort or the last diagnosis to come. It should be at the beginning in your differential diagnosis in children to diagnose pediatric TB. And unlike in adults, children are very difficult because their physiology changes, their immune system changes over the years. So their presentations vary with the age. So if you look at this breakdown in a very younger child who is less than 1 year, so though it's mostly maybe with pulmonary disease, 30 to 40%, and tuberculous meningitis or miliary disease in 10 to 20% of them. But if you look at a child who is more than 10 years, around 10 years, so it is coming more of similar to adult presentation. So the 10 to 20% of pulmonary disease and tuberculous meningitis and miliary disease in very minute percentage of people. So, and interestingly, if you think of tuberculous natural cause, so you can see all the stages among a child. So you can see the primary tuberculosis in infancy, and then you can have latent TB, and if you do a MAN2, you will get a reaction in an asymptomatic child, but no clinically overt disease. So you have latent TB, and then less than 10% of them, they can progress into disseminated disease, as well as later it can leads to post-primary disease. So when you're dealing with a patient, a pediatric patient, it's really important to remember it's not just adult eye presentation with cough and cold and fever with night sweats. So often you can't explain or expose these facts from the history. So it is important to think pediatric TB as an important differential diagnosis. So I thought I will bring down a couple of patient histories to make it interesting. So this was a 3-month-old baby who was coming with high spiking fever, cough, and poor feeding, despite outpatient treatment for 2 weeks. So on admission, because it has been more than 2 weeks, and chest x-ray was done, so it shows right upper lobe pneumonia, and then so it kind of a initial thought was a bacterial pneumonia, and then the investigations also suggestive the high WBC with neutrophil leukocytosis, CRP96, normal renal and liver functions with the ESR of 80. But appropriate antibiotic, IV antibiotic for more than 7 weeks, no response, and then the team repeated the X-ray. There's no change in the radiologically, and child was continued to spike fevers. So, and then the CT was performed and found to have huge mediastinal adenopathy, compressing of the left main bronchus and leading to this poorly resolving pneumonia. But here the turning point was looking at the CHDR, the child's identity card. It shows how the child's growth was. Even though the child was presented around 3 months, here the growth faltering has started month before. So it is really important to look at the child's CHDR when we are thinking of long-standing diseases. And this is another patient who again was presented at 3 months of age. So he was from Ratnapura, transferred to Lady Ridgeway Hospital neonatal intensive care unit at the beginning. So he was second born at the term and developed respiratory distress at the 2nd week of life. And so child was initially admitted to Ratnapura Hospital, and they had to intubate the child and transfer to LRH. But child had a complicated pneumonia, a stormy period, and end up with having left-sided chylothorax. And then it was aspirated, treated with antibiotics, and then child was discharged. But next day child is readmitting with persistent respiratory distress and fever. So when you take the X-ray, so there was encysted pneumothorax. And then this was not a usual presentation at this age. So the immune deficiency screening was arranged. And then we found that there was a positive NBT test suggesting that child is having a chronic granulomatous disease underlying. So, and then the ultrasound abdomen shows there was hepatosplenomegaly, and then later parents admit that their previous child was died at the similar age, and then later we could found the post-mortem report which was diagnosed TB. So we have to be very careful when babies are having uncomplicated stormy period. It could still be TB. So it is really important to keep these facts in mind. Right. So as I said, the consideration of underlying immune deficiency is important in children. So we have specific primary and secondary immune deficiency conditions that may predispose children to the tuberculosis. So congenital neutropenia, neutrophil function defects like chronic granulomatous disease, and there may be secondary immune deficiency secondary to drugs, anti-TNF therapy, because nowadays most of our rheumatologists use anti-TNF therapy in rheumatological condition, even in children, and then who are having childhood neoplasms on chemotherapy, and interestingly, the retroviral infection. So it is really important to remember children who are with immune deficiency have more predisposition to develop TB. And then I just speak one few words about the MSMD. So this may not be very familiar to every one of you. So this is a genetic disease we say it's the Mendelian susceptibility to mycobacterial disease, but it is a misnomer. It is not only for mycobacterial disease. It is also for the other non-virulent organisms like non-typable Salmonella, Listeria, Klebsiella, and some of the viruses like CMV. They are more predisposed. So what is really happening here is like we know when a mycobacteria are coming, the macrophage, monocyte dendritic cells engulf them, and then it get activated, and then it started producing IL-12, and then which goes and hit the T lymphocytes. So T lymphocyte contain the receptors, and then the activation of these protein pathways go through the tyrosine kinase 2 and JAK kinase 2, and then which produce interferon gamma, which again go and hit the monocytic dendritic cells, and you have receptors here for that. So if you look at this interconnection between the monocytic dendritic cell and the T lymphocytes, so if there's any defect in anywhere in the receptor or in the ligands, so this process doesn't progress properly, and then that will lead even for a non-virulent, low-virulent mycobacteria and other bacteria to give rise to significant disease in children. So we should consider when the child is having disseminated BCG infection and when there's low virulent environmental mycobacteria, and especially recurrent episodes of tuberculosis. Mostly it's coming with tuberculous lymphadenopathy, and then recurrent salmonellosis. Maybe they might come with repeated osteomyelitis with salmonella infection. And then interestingly, so usually when they come with abnormal clinical picture, we tend to do the immunological screening. So, but there's no help, immunoglobulins, lymphocyte subsets, and NBT test, everything's negative. So in that case, we have to remember that there is a condition like MSMD. We need the help of the immunologist at this point. Right, so let's move to the sampling, where this is the next difficult situation when we manage or diagnose pediatric patients. So if you think of pulmonary disease, so we have options of gastric lavage, and so ideally 3 samples, and then so gastric lavage, often what we do is in the morning, when the nurses come and the doctors all hold the child and put the NG tube and then try to take a sample. But ideally the NG tube has to be inserted in the previous night. And then in the morning, as soon as the child wakes up, you have to take the sample. So otherwise, it will take a longer time after child wake up to get the gastric lavage sample. So that reduces, anyway the gastric lavage sample, the utility is very low, but we can get about 30 to 40% utility. But with this delays and the problems with the procedures, even we lose that probability of getting a proper sample. And the sputum induction, we can do it in children, ideally in a negative pressure room. We don't have it existing, so often take to a specific room, separate room, and we can get the help of the physiotherapist for the sputum induction. And the yield from the sputum induction is much better. And then in all the children, you can ask to expectorate sputum, and then hardly we can do a bronchoalveolar lavage because it's very difficult to get a bronchoscopy time. So when you say it's probable TB. So, and then in literature, so they discuss about the string test. You might have encountered, but we haven't done it in Sri Lanka. So what we do is, like a string is made into sort of a capsule, and then child swallow it, and then in the morning you can take it off and then culture that. But there has been some less sensitivity and high specificity in the sample, but at the moment WHO or anyone does not recommend as a routine testing for sampling. And then if we move to the extrapulmonary diseases, so the lymphadenopathy is the commonest pediatric extrapulmonary disease. So we can do mainly the biopsy, and then before that we can get the help of the radiologist to do the ultrasound scan, identify the best lymph node, and with the good caseation. So that is lymph node, and as Dhamika madam mentioned, so we can use do gene expert on these samples. And then CSF, as madam mentioned again, so we can take only very little of CSF from the children, so it is often challenging. And then pleural fluid and pericardial fluid. So unless you have the pleural TB or pericardial TB, you will not get a positive culture, because it can be a reactive effusion as well. So pericardial fluid, it is very important. If you do a pericardial tap, please do send all the samples without a hesitation. And then in disseminated disease, we can do the liver biopsy, bone biopsy, and bone marrow biopsy. So it is really important to remember that we can use all these samples for diagnosis of TB. Having said that, all these are invasive, discomfort for the child, most often not enough sample, poor yield, and you need expertise to interpret this report. So it is again make your things difficult. And then if we move to the radiological evidences, in pulmonary imaging, so the mainstay is the chest X-ray and then the CT. Common radiological abnormalities that we see among children is mediastinal and hyaluronopathy with central necrosis, and then there may be air space consolidations, and then hardly we see consolidation with cavities, and often you can have disseminated pulmonary nodules, especially in the younger children as well as in children with immune deficiencies. And then if you think of extrapulmonary imaging, we have a lot of options, because in children we have mostly encounter disseminated disease and extrapulmonary disease. So we can get the help of the ultrasound scan, 2D echo, CT, MRI, and contrast studies. So in the CN, most challenging issue here is, so even though you see these lesions, those are not always the pathognomic for the diagnosis. And then it is really important to correlate them clinically. For example, if we move to the mesenteric and bowel wall thickenings, so even a child with chronic granulomatous disease, they will have granulomatous formation and bowel wall thickening. And even a child with Crohn's disease, again, they might mimic similar pictures. So it is really important to think of other possible differential diagnoses and to clinically correlate the radiological findings. Okay, so let's move to the perinatal tuberculosis, the other difficult situation that we face. So perinatal tuberculosis is an encounter where the infant and the mother, between the infant and the mother with tuberculosis. So during the intrauterine period or during the normal birth process and during the immediate postnatal period. So we have to remember, in an infected mother with tuberculosis, whether it's pulmonary or extrapulmonary, so they can infect their kids. So because the infection of the placenta and maternal genital tract can transmit vertically the bacterium to the fetus. So there is a spread of hematogenous spread from placenta to the umbilical vein. So most commonly we see the congenital TB in the liver, because that is the most aerobic area, because the umbilical vein goes and meet the ductus venosus there, and you get the periportal area is the most oxygenated tissue in the fetus. So we will see mainly the primary hepatic complex rather than pulmonary complex in a adult. And then it is possible to have aspirations and ingestion of amniotic fluid during the birth process. And then postpartum, so there may be direct transmission of the infective material. To diagnose congenital TB, there has been suggested criteria for ages, and mainly the Canterville criteria has been used. So we have to demonstrate Mycobacterial tuberculosis lesions, and as I said, we have to show that the primary hepatic complex or caseating hepatic granulomas. That's why we suggest to do ultrasound scan of the abdomen and the portal area. And then you have to detect these lesions during the first week of life, and then also we have to exclude postnatal transmission. And interestingly, this is not really happening with us. So the tuberculous infection of the maternal-genital tract or placenta. So it is recommended whether we could recommended to send the placenta for histological examination, but it's not happening most often. So in neonates, the common presentations, they could be born prematurely with a low birth weight, and they are having poor feeding or failure to thrive, and maybe respiratory distress, hepatosplenomegaly, adenopathy. Those are the common presentations during the neonatal period. And if we look at the current Sri Lankan guideline recommendation in the management of perinatal TB, so we are mainly concentrating on the pulmonary TB mothers. So so the management differ based on whether you're smear negative or the smear positive. And if it is smear negative and child does not have evidence of congenital TB, and then BCG is given and discharged, but you have to follow up these patients at least for 2 years. So we need to have a coordination with the pediatrician and the family midwives and MOH to make sure that child is not lost to follow up. So they should attend to regular weight measurements and the development assessments. And then if the mother is positive at the time of delivery, so we have to screen the baby for active disease. So often the liver ultrasound scan and gastric lavage for some TB culture and smears and the gene expert, and then chest x-ray to be taken. And then if these investigations suggestive of active TB, so start on anti-TB treatment, and then if it is negative, we withhold the BCG and give the INH prophylaxis. And after 3 months, you re-evaluate the baby with a MAN2 test, and if it is MAN2 is negative, you can stop the INH and give the BCG, and if it is positive, again you have to look for active disease, because how the baby was sensitized with the tuberculous infection. So, and if there's no evidence of active infection, then it is recommended to continue the prophylaxis for 6 months and to give the BCG. So that is the current recommendation to Sri Lankan babies who are born to mothers with TB. And I thought I will just touch a brief on the BCG vaccination and complication, because we see them very commonly. So it is a live attenuated vaccine given derived from Mycobacterium bovis, given intradermally, except for children who are having primary immune deficiencies and babies born to HIV infection until their CD count and the viral load is detected. And then if the baby is not developing a BCG scar by even by 6 months, then you can, sorry about the spelling mistake, you can repeat the BCG vaccination, and until 5 years, you don't need to do a MAN2 before giving the repeat BCG vaccine. And more than twice vaccination is not recommended either. So this is one of the patient we saw recently. It was a 10-month-old baby, well and with normal growth, and parents bringing the child with a boggy mass in the BCG side. And so the pediatricians being treated with oral antibiotics as per our guideline, but there was no response to that. And then the ultrasound has shown there is a hypoechoic area with echogenic material in the subcutaneous tissue. So this was a BCG abscess, and then we had to start on INH prophylaxis, INH, and then now the child is getting better. And then this slide is coming from Dr. Channa. He wanted to share this with y'all. So this is one other baby recently seen, again coming with BCG adenitis. So this is again a common complication of BCG vaccine. So you can get unilateral axillary lymphadenopathy with sometimes abscess formation, and then maybe in the same side in the cervical adenopathy. But unfortunately, child had a surgery, and now it has become an unhealing ulcer there. So we have to be very careful when you prescribe a treatment to a child with BCG adenitis. So INH we could have treated, tried and see before going into the surgical excision, because it gives you a devastating scar and an unhealing ulcer. So last bit about the current recommendations on using the prophylactic INH prophylaxis. So we can use INH prophylaxis for infants with smear positive mothers, as we said, when they don't have active disease. And then all the children who are less than 5 years in a household with a sputum smear positive patients. So, and provided that they don't have the active disease. So this is really, really important, because we see some of the children coming with devastating outcomes, especially with CNS TB. And then the retroviral children who are having close contact with smear positive TB. So the dose that we use for prophylaxis is 10 milligrams per kg for 6 months. And then there is a controversy about the treatment of screening and treatment for latent tuberculosis infection. So I will leave that as Dr. Ishanta will discuss this further. But this is among children, it is mostly the case based because there may be children who are awaiting anti-TNF therapy and maybe long-stand steroids and in immunosuppressants with a high prevalent area or like having high risk factors. So whether we need to consider screening and starting on prophylaxis. So apart from these clinical encounters, I thought we have a couple of other challenges when managing pediatric patients. So some treatment regime preferences. So I know that the most neurologists like to use streptomycin for the as the first line treatment, but we have to remember the ethambutol, it does have a very good CNS penetration, and then some do not prescribe ethambutol for small children. Actually, the ethambutol dose that we use does not, the literature hasn't shown the toxicity to the retina, and then the dosage that I need to specify, because now it is easy since we don't have the pediatric preparations and the weight categories, so we tend to prefer look at the weight and just to give the number of tablets written in the guideline. But often children, if we prefer, if we can go for the exact dosage for the children, because they have high metabolic rate and the overdosing is very unlikely. So better to use the appropriate dose per kg basis. And then at the same time, in a children as in adults, we look at the patients holistically. So there is a component of nutrition, improving their malnutrition, and then make sure they get the immunization. There's no contraindication for their EPI vaccinations. And then remember, they have the right to continue their schooling and academic performance. So make sure that once the infectious period is over, please let them go back to school and help them to support them to reduce the social stigma towards them. And then again, as a program, we have couple of challenges when managing patients. So because most often we are concentrating on the people who transmit the disease, and then we often go by the symptom-based screening. And the contact screening, it is suboptimum at the moment. So we would like to request everyone, please do contact screening for the smear positive adults, because the children are coming later with devastating outcomes, especially the CNS TB and miliary TB. So if we lose a child because we haven't screened them and not given immunoprophylaxis, so it is the negligence of the healthcare system. So we need to consider, and I would like to stress more on contact screening. And then also we need to correct our health professionals' myths and misconceptions, because those are conveyed to the patients, parents, and then again the referral pathways and transition care, especially from pediatric to adult care. We need to have sort of a smooth transition during this period. So I think altogether, when we get together, pediatricians and the adult physicians and everyone in the healthcare system, we can make this, we can beat TB. So let's beat TB. Thank you.
Thank you, Dr. Jayaratne, for excellent comprehensive lecture. I think we have little time for a question or two from the audience. Unfortunately, online viewers have not sent us any questions.
I was asking whether adenosine deaminase is being used in children with pleural TB, and whether I think was it Anuradha who was collecting some data on pleural adenosine deaminase and cutoffs in children. What are your views and experiences on this?
ADA is important in difficult situation, because when there is pleural effusion, and then when we can't get a pleural biopsy, and then I think ADA is important, though we are not using like more specifically, but ADA amount is validated, so we can use it in a lymphocytic exudative pleural effusion, and ADA I think give us a guide. And then with amount to being positive, and then I think that is more in favor of diagnosing TB.
Is there any evidence of would we be using the same cutoffs as in adults?
So as far as I know, we haven't done sort of different cutoff values for the kids. Here, I think the data collection has not been completed, and it is not out yet. But generally, we use the same cutoff, 35 to 40.
National Hospital now, Dr. Katlanda, our chemical pathologist, has made ADA available.
Right, sir.
I mean, I don't know how things will evolve in the future, but up now we have had ADA available. We have made strong recommendations for the campaign also to provide this in our strategic plans.
Right.
But yet this has not happened.
Okay.
Okay.
Thank you, sir.
And thank you very much for the lecture. Right. Now, I think then after few lectures, it's a bit of time for us to relax. We are breaking off for the tea, and meantime, I would like to my pleasant it's a pleasure for me to inform you about this, the song that Dr. Shanta Perra and some of my colleagues have made to bring the message of tuberculosis to the masses. And it had been a success with so many viewers, online viewers. We will play this song for you to enjoy. Thank you.
සුසුමන් පවා උණුසුම් වෙලා වාතලය කලබා සැඟදී ගියාදු කඳුළු රහසේ ඉඳගන්න පෙර පුරුදු දිවියම
නිසි කලට පිළියම් ලබන්නට සුවය පවනෙමු නුඹේ අතුලේ
තංගල් වෙලෙත් ඉරවුනින්දදු
Gentlemen, welcome back after the short break. Now we'll carry on with the program with the next speaker. To talk on the hidden threat of latent tuberculosis, we have Dr. Eshanth Pereira, Consultant Respiratory Physician, National Hospital of Respiratory Diseases, Valisara. Dr. Eshanth is in the editorial board, Chief Editor of the Latent Tuberculosis Guideline to be published by the NPTCCD and in collaboration with the Sri Lanka College of Pulmonologists. Over to you, sir.
Thank you, Ravani, for the kind introduction. And today I'm talking about latent TB infections, and this is a new thing which we need to, which we revised as a guideline recently. Latent TB is in a state of persistent immune response to stimulation by MTB antigens with no evidence of clinically manifested active tuberculosis. As the previous speaker said, that the WHO set up some targets to end TB by the year 2035, and it really identified the diagnosis and treatment of LTBI as at a wider scale as an important step in ending TB globally. In 2018, they issued a basic guideline to assist the member states, but it was not a detailed guideline. With that in mind, and they also suggested to go ahead with the 8 nations to go for their own guidelines setting, considering their epidemiology and other factors which are important to set up a guideline. By that time, the LTBI strategy, treatment strategy and investigations was just to offer INH for a limited risk group of children less than 5 years of age, and those who are on biologics and those on retroviral infection and few other groups, but they were practiced differently in different parts and different clinicians. So therefore, we needed a new guideline on LTBI and for programmatic management of LTBI in Sri Lanka. A guideline is a set of rules or instructions given by an official body telling you how to do something, especially one which is difficult, which is difficult to practice. It's a useful diagnostic, a useful tool designed to aid the basic clinicians. So with that in mind, we set up a guideline development group of Sri Lanka, a joint effort of the College of Pulmonologists, the clinicians, the pulmonologists and the pediatric pulmonologists, together with the WHO and National TB Program specialists as well. As I said, the LTBI guideline is useful not only for the pulmonologists or the pediatrician, it will be useful for many other specialists, including the rheumatologists, the venerologists, and the nephrologists, and the transplant teams, and so on. So when we consider the guideline, we have 4 key areas to identify, like the identification of the risk groups, developing algorithms, testing for LTBI and active TB disease, and also the clinical and programmatic management of the LTBI. As Dr. Dhammika this morning said, when you talk about TB and complex diseases, this affects many difficult, many straight out people, or different kinds of patients and different settings. Therefore, you need to develop these algorithms, and they are very important to follow because there is no set. As I go along, you will understand that there are no well-set plans to this is the ideal situation for all people. This is not going to be the case because it's going to be different from case to case. First of all, I talk about testing. Testing includes basically, as I said earlier, you should, in LTBI, there is no clinical active TB. So you need to detect any unrecognized active TB first. And also, when the testings are done to prevent endogenous reactivation of undetected TB or the latent TB infections. As you all know, the active TB detection is very straightforward. The exposure histories, leaving the local and travel histories, including the symptoms criteria or the 4 symptoms criteria, the main symptoms of TB and chest X-ray findings as is initial screening tool. And then again, you go for the microbiology of these tests of these patients. if you consider the LTBI test, as I said earlier, there in LTBI, in the latent TB infection, there is no evidence of clinical manifestation of active TB. So you have to go by, it's a persistent immune response to stimulation by MTB antigens. Therefore, you have to go by the immune-based tests such as TSTs or tuberculosis sensitivity test and IGRAS, interferon gamma release assays. They are the quantiferon gold test and the T-spot or T-spot TB test. When you consider both these tests, I mean the TSTs or the IGRAS, there is no gold standard test. Both require a competent immune response to react, and disadvantages are mostly similar in these settings. The test responses are different in certain clinical risk groups, and most of us use the TST alone, and in specific clinical settings, both TST and IGRA will be used. Who will need LTBI testing? The children under 5 years of age do not need testing for LTBI before offering TPT or TB preventive treatment. But almost all the other groups will need testing for LTBI. But when you do LTBI screening and you interpret them, you need to remember these common things like with increasing immunosuppressions, there will be a decrease in sensitivity in both these test groups, the TSTs and IGRAS. And there are important practical consequences. Screening should be ideally be carried out before impending immune suppressions. For example, before starting dialysis or transplant or administration of immunosuppressive drugs or the anti-TNF alpha treatments, you need to do the screening before starting these treatments. If you consider a TST, the cutoff value for TST in duration, as I said again, in duration, not the visible thing, the in duration, palpable in duration, for immune competent person, it will be 10 millimeters or more. For immune suppressed, it is 5 millimeters or more. Remember, the size is what matters, not the test positivity or negative. As we've been telling this for many times, but we almost always see in many hospitals, they just write TS amount to positive or negative, just not giving the size of the reaction. So you need to tell your staff or the interpreting staff or the nurses or whoever who does the reading, measure it across in millimeters to record it in millimeters, not the size positive or negative. So you may come across this term called the boosted reaction in TSTs. As you know, some infected individuals with MTB may give a negative reactions to TST if many years have passed since they became infected with TB. So this is called cutaneous energy. However, they may give a positive reactions to a subsequent TST because the initial test stimulates the ability to react to the test. So this is commonly referred to as a booster phenomenon. This cutaneous energy will result in a false negativity in these patients. This is very important for us to interpret when you are offering, because you are testing the immune response in LTBI. But if it is a cutaneous energy which has given the false negativity, you will be deceived with the idea that it is something which is a no LTBI infection. This is minimized by a two-step TST. It is valuable in this setting if the TST is the only test performed. It happens in many situations that you cannot go for IGRAS because IGRAS are expensive, is not available in the nowhere available in the state facilities. So sometimes you have to rely on TSTs. So if the TST is your only test and it's going to be affected by cutaneous energy, so two-step TST might come handy in this situation. And also evaluating specific groups, also TST two-step will be useful. Here, it is optimally carried out. The guidelines are like this. Once you place a mount to test on a patient, and ideally you have to repeat it in between the first and 4 weeks of the first one, and you go for the reading. In general, the CDC says there is no risk associated with repeating the TST placements. But then again, we come across this common situation also. A person who has had a TST done will not return within 48 to 72 hours as we have been expecting for the reading. So second, in this situation, it is advised to place a second test as soon as possible and interpret. If I compare the IGRAs, there are two IGRAs as I said. The sensitivities of TST and IGRAs do not overlap fully. As I said, the implications of their usefulness also may not overlap fully. So when you compare the quantiferon and T-spot, in quantiferon gold you measure the interferon gamma concentration, but T-spot you measure the number, count the number of IFN gamma producing cells or spots. Here, the one important practical aspect is when you collect blood within about 16 hours, you have to process and with regard to quantiferon. But if it is T-spot, is roughly around 8 hours. So when we developed the guideline, we recommended that we would be going for, if it is going to be made available for the state sector, we have to go for the 16-hour thing or quantiferon GIT. But then again, you have to be very mindful. Now, if you are sending samples to the private sector also, now it may happen if you are a consultant or a medical officer working in somewhere in a periphery. If you give the sample to a peripheral laboratory who is a collecting center, that might take another time to deliver it to the main center in that area. Say, if it is in Ratnapura, somebody is on the collecting small collecting center may dispatch the sample to somebody, and that 16-hour period will easily get and passed, and you may not get the appropriate results. Both TST and IGRAs are required sometimes. So as in the case of solid organ transplant and various clinical settings, I'm going to talk about. And in these situations, ideally both should be done on day one. I'll give the reasons, because now once the tuberculin, which is pre-PD or what, the protein is placed in your arm, that it's some of the antigen itself will be acting like a stimulus for the quantiferon test as well. So to minimize it, they have advised to have it ideally for practical reasons on the same day with the TST. You may take blood for quantiferon, but the problem is people have to come prepared for it. The cost of it was ranging around 16,000 to 22,000 depending on the laboratories, and people will not come with that kind of money to our hospitals, don't they? Will they? So they are in these situations. We will have to get them, and we have to advise them. So probably the second option will be TST performance on the day one, and if negative, the IGRAS performance on day 3. That is the cutoff being given on literature. So when they come for the reading, you may have to tell them, when you are coming on the next day, if the test is negative, you will have to go for this quantiferon test. It will cost about this much of money, and they have to come prepared for this when you come for the reading. There are special situations as well. Patients with very few special situations I'm going to discuss. These are actually, those are the situations which you have to follow on an algorithm. Like, if a patient with documented past records of positive TST or IGRA, and if you are thinking about the context of LTBI, first you have to exclude active TB in all situations, and retesting for LTBI is not required at all. And then the second situation, if somebody who has been reliably treated for LTBI or active TB disease, there again you need to exclude active TB, but again retesting for LTBI is not required. Third situation, asymptomatic person with chest X-ray evidence of past TB without a history of adequate TB treatment in the past. This is a very common scenario also. Asymptomatic chest X-ray showing past TB, but hasn't got any proper treatment, then again you need to exclude active TB. They are regarded as LTBI if active TB is negative, irrespective of their TST or IGRA results. Fourth scenario, if an active TB is suspected on other grounds, more advanced diagnostic tests like microbiology or histology on other clinical specimens and HRCT may be useful. For example, HRCT may give some evidence of endobronchial TB. Okay, I'm moving to management of LTBI. As I said earlier, the drug management of or TB preventive therapy, or in short form, we call it TPT, and programmatic management of LTBI is also there. In TB preventive therapy, 3 options we have identified for Sri Lanka. That is 6 months of INH monotherapy daily for 6 months for 6H, or 3HR, that is INH and rifampicin. We know the shortened forms we use for HNR for INH and rifampicin daily for 3 months, or 3HP, that is INH and rifampicin once a week for 3 months. That's about 12 tablets over the 3 months course. While on treatment, LTBI treatment, we need to observe them for development of active TB disease, and also inquire about exposures to PTB patients. If there is a significant exposure, we need to investigate for active TB. And if you think that they have already got active TB, you need to reinitiate LTBI treatment after excluding active TB. Only we need to start LTBI treatment again. And also, you need to monitor for adverse outcome of INH or rifampicin therapy as well. One important thing is, LTBI treatment is not routinely recommended for patients who have been adequately treated for active TB disease in the past. Not routinely recommended if they have been. But always you need to exclude reactivation of TB, but you don't have to go for LTBI treatment again. Finally, the most important thing is identification of the risk populations. We have 3 risk populations identified by the WHO. There's people living with HIV, and there are 2 other HIV negative groups. Those are the immune competent close contacts of persons with TB, either bacteriological or clinically confirmed. The other HIV negative group is a clinical risk group with immune suppression. The second group is immune competent close contacts, and clinically risk groups with immune suppression, irrespective of their contact status of TB contact status. PLHIV groups, there are 4 sets identified: the infants, that is 12 months of age, and the children aged more than 12 months up to the year of 5 years, and the children, older children of after 5 years, and adolescents and adults, and those finally the adults and adolescents who have been treated for TB in the past. This group, I earlier said that you do not have to consider them for TPT, but you need to exclude relapse if they have been properly treated in the past. But infant under 12 months, TPT is only, that's not routinely recommended to give this HIV positive, but TPT is not routinely recommended unless they are in contact with TB, known household contacts or otherwise, because you assume at the situation that those who are under 12 months of age may not be going on their own out, and unknown contacts are less possible in this group of patients. And children over 12 months but under 5 years, irrespective of their contact history of TPT is given, because they are risk, as in the immune competent group also of children who have had contacts, we be giving treatment, but here, irrespective of their the contact history, they will be offered TPT. But those who are over 5 years and adolescents and adults, we were recommending to go for IPT for these patients also, but they are again the vendologists. When we put the guideline to them, they suggested there will be lots of issues we need to consider when we are, blankly going to offer TPT for all these patients, because the drug effects on the liver and so on with their ART is going to cause problems. So we thought at that time, if they will be tested for LTBI, the immunological test. If they become positive, TPT will be given. Then this important group of the commonly known group of HIV negative but immunocompetent people. Now, everyday practice we come across these patients in new TB patients and contacts. Whether the bacteriology confirm or clinical diagnose, to offer to close contact to offer TPT is the recommendation. So, who are these close contacts? They are any persons who repeatedly and regularly share the living space with a person having infectious TB. They have got further subclasses like household contacts and the non-household contacts. The household contacts are the ones who are sharing the enclosed living space with the index patient one or more nights for frequent or extended daytime periods during the previous 3 months. The non-household contacts are the ones who are not in the household but shared an enclosed space such as a social gathering place, workplace or a facility for an extended period during the day or the 3 months prior to this presentation. Okay, so these contacts, how are you going to offer TPT? As they are not the HIV, they are the HIV negative groups. Infants and children under 5 years of age, if they have household or non-household contacts, we will be offering TPT without LTBI testing. But more than 5 years of age and adolescents and adults who are household contacts will be tested for LTBI, and if positive, TPT will be given. But those who are non-household close contacts, individually their risk will be assessed and will be offered LTBI if they become positive with the LTBI test. Those with MDR TB individually will be assessing and offer, because what kind of TPTs we are going to offer is going to be very complex. Finally, the third group of people, they are the HIV negative again. They are clinical risk groups with immune suppressions. Irrespective of their close contact or otherwise, we will have to offer LTBI treatment if they are tested positive for LTBI. The groups are the patients who are to be initiated on anti-TNF alpha treatment, those who are receiving dialysis, those who are getting prepared for SOT or solid organ transplant, and those who are going for hematopoietic stem cell transplant, and also the very important group of people are also in this occupation setting, the silicosis. There are other two groups which are going to come later on in the guidelines, but we will not be considering them initially as in the programmatic management of offering TPT. We will not be immediately considering these groups like socially vulnerable group like prisoners, drug addicts and immigrants from TB burdened countries, and occupational vulnerability like in healthcare workers will not be there on the lower stages of lower priority when we implement the program. If you consider the specific situations like those who are receiving dialysis, here both after the clinical and the basic screening and all, the two-step TST and both IGRA, both are recommended in these patients. Especially two-step will be going if you are not doing both IGRA and TST together. And those one solid organ transplant, there are 4 scenarios where after a transplant a person can develop TB. We have been coming across these patients several times. If a SOT patient develops TB, there is a high risk of dying. It's about 33% mortality in these patients if they contract TB or develop TB while post-KT period. So there are few scenarios, latent TB infections in a candidate recipients after his own LTBI got reactivated, or you got a donor graft with TB, it gets TB thereafter, the recipient gets TB, or after KT or after the transplant, somebody gets exposed to TB and develop TB, or the patient candidate may have active TB but requiring urgent transplant for obvious reasons. So the procedure to follow in SOT is evaluate. You need to evaluate both the candidate and the donors. It's very, very much known that we always evaluate the candidate or the recipient. But I do not know whether it's very routinely practiced, the donor screening, whether it has been recommended that both living and the deceased donor organs should be evaluated for the presence of TB. So obviously the reasons been outlaid here. When you evaluate the transplant candidate, both tests are recommended. If you are not going for both IGRA and TST, two-step TST have to be done. But you have to interpret the reading of the TST according to the immune state of the patient. You need to remember that all organ failure patients are anyway they are immunosuppressed. Therefore, due to their treatment or their disease per se, so you need to interpret the TST result accordingly. If you are evaluating the disease of living donors, you need to remember the test induration value is they are healthy people. Therefore, the induration is of the TST is 10 millimeters or more. They are either TST or IGRAs could be done because the interpretation of the LTBI test are very simple in these normal individuals. Even in a living donor is tested positive, organs should not be, if positive for active TB disease, organs should not be used immediately if possible. Active TB should be treated with a standard ATT and they should be reevaluated for active disease later on after a time period. But if they are positive for LTBI treatment should be considered prior to organ donation, and it is advisable to complete LTBI treatment prior to the transplant. This then comes the deceased donor evaluation. It's not easy because when you have a deceased donor, say somebody met with a road traffic accident and you have couple of organs to 5 organs to both lungs, the liver, kidneys, they are available for transplant. They will be in a hurry to anyway transplant rather than looking for TB in these individuals. So it's not easy to find the data also. So initial evaluation will be from obtaining a detailed history from the donor's family or the relatives, and if available, the past imaging studies of X-rays and all. And if they are with high risk of TB, then you need to go for these tests if possible. But TST is not visible because the donor is now dead. And IGRAs, whether they are going to give the same amount of after death, whether they are going to have once the blood is drawn after a period of time, whether they will give the same response of the T cells, it's questionable, and there are no studies to compare, and therefore your interpretation is going to be difficult. But if you have to somehow go ahead with the TPT, the transplant, it is preferable to initiate. If you don't have any thing to go by, you may initiate TPT in the recipient depending on the circumstances, but active surveillance of the recipient is suggested for development of TB later on. Hematopoietic stem cell transplant, same thing, both TST and IGRAs are important. Here again, there are two groups again, more than 5 millimeters for recipient and then 10 millimeters for the donor. Patient on biologics. There are two groups of biologics as far as LTBI is concerned, that is anti-TNF-alpha therapy and non-anti-TNF-alpha targeted biologics. TNF-alpha biologics are very important because TNF-alpha and other cytokines play an important role in the reactions that will kill the TB bacilli. So, different groups of anti-TNF-alpha agents, commonly the infliximab, the golimumab, and those things are available. We commonly use infliximab, but in certain instances we have used this as well. And they are having an increased risk of developing TB when if you have not excluded LTBI, because it causes reactivation of TB. Here again, you need to do both TST and IGRA in this step, and sometimes you need to go for the two-step TST because IGRAs are expensive in this context as well. If the ideally you need to diagnose and treat LTBI before initiation of anti-TNF alpha treatment, but LTBI testings are negative now, then you can give anti-TNF alpha treatment could be commenced. But you need to be aware of the false negativity reaction, because these patients are anyway, because of the disease or due to immune modulator therapy, they are already immune suppressed, they may have false negative reactions. Therefore, close monitoring of these patients for development of active TB is very, very important. If they have been on TST interpretation, again important, if they have been on immunomodulator therapy, more than 5 milliliters will be considered positive, and others will be considering 10 millimeters. Ideally, TNF alpha treatment should be started at least after 4 weeks of initiation of LTBI treatment, and close monitoring for development of active TB disease should be again be kept in mind. If the patient develop active TB disease, TNF alpha antagonist should be stopped immediately and ATT should be started, and you should restart TNF alpha agonist after 2 months of intensive phase of ATT once a good response to anti-TB treatment has been received. Non-TNF alpha targeted biologics, there are a group of people, a group of agents are there, and they are important agents as well. But very importantly, if somebody is LTBI positive, investigate positive, and you have to read a biologic, then non-TNF alpha treatment may be the safest option. They need not to be commenced on the LTBI treatment, and will have to be followed up 3 monthly at the district chest clinic. Since they are less problematic, their effect on TB are negligible. Therefore, the guideline development committee decided they to be screened, but no need to be offered LTBI treatment in this group of people. Finally, the final group of people are the silicosis patient. Research has found on many times it has been proved that there could be a coexistence of TB in this patient with silicosis. So clinical assessment and the basic things will be done, and where relevant other investigations will be done as well. Here again, how to interpret the TST. If they are having more than 10 millimeters in duration, that is considered as positive. But if somebody is having induration more than 5 millimeters, but still having fibrotic chest exchanges suggestive of prior TB, may offer individually selecting them how you are going to may offer LTBI treatment. So with that, I conclude my talk. I'm happy to take any questions. Thank you.
Thank you, sir. That was a very comprehensive summary of our local guidelines. In the interest of time, we can take one question. Are there any questions from the audience?
Thank you very much for the difficult topic and covered the comprehensive areas. Is there flexibility to, can I have 2 questions?
Yes, sir.
One is autologous bone marrow transplant in multiple myeloma patients. Should they also have go through the same process of screenings? Most of the referrals we are getting with patients with multiple myeloma who are referred for this latent TB to screening for latent TB. Otherwise, do we have the flexibility of using any of these 3 regimes in these people, like the rifapentin INH regime once weekly? Do we have the flexibility, or is it confined to a specific group?
No, we haven't identified. I answered the second question first. We haven't identified the specific disk groups. Different 3 options. Basically, the 3HP may be offered later on for practical reasons. Sometimes, maybe when we introduced for the healthcare workers and all, for practical reasons, we may that the rifapentin is not available anyway. We need to get down that, and we have not budgeted for that. So probably it at a later stage.
Now you mentioned about donors, kidney donors. Is it option for such a group? Because
at the moment we don't have, but these are the available options we have decided. But out of the drugs we have only H and R, as you know, in our armament for anti-TB treatment. But rifapentin is not available yet, and with regard to your first question about multiple myeloma, we did not specifically consider as a different entity, like, but we have lots of. I don't want to put it on record. We have getting lots of input from the transplant teams that saying that they did not have any problems with TB so far, and why should we go for this screening and all these things?
Patients.
Except for the KT patients, but it was the same with, I think maybe that the teams may not, some teams may not be aware after many years whether these patients are coming with TB. We have had over the last year, we have had 3 patients, all 3 died after KT. One was 12 years after transplant as TB. So once they get TB, it's a killer. So your transplant, or money and your organs, everything is going to be get wasted. And finally, we did not put it as a guideline without discussing with the others. We talked to them. We circulated the guidelines among all the specialties and the colleges, got their inputs, and finally came to this consensus of this. So multiple myeloma per se, we did not discuss, but with regard to pediatric population with hematopoietic stem cell transplant, when you evaluate them, the BCG's effect on them is going to be another issue, because the pediatric population, the interpretation of BCG vaccinated people with the Bantu test, so the IGRAs may come more handily there.
Thank you.
Thank you.
Thank you, sir.
Thank you for the informative lecture. You spoke about treatment for TNF therapy and non-TNF biologics. The question is, because we get a lot of referrals of patients going to start rituximab, which is a CD20 antibody inhibitor. So in these patients, do we screen for latent TB, and how do we manage if they become Bantu positive?
Rituximab, of course, it has not been mentioned as one of the important things. As we put on the guideline as well, not anti-TNF alpha. Therefore, we did not recommend to screen for them, but we recommended to screen them, but not to offer LTBR treatment for them. But probably they may be referred to the chest clinic, maybe for 3 monthly reviews.
Thank you, sir.
Thank you, sir. So next we'll move on to the next topic, which is drug-resistant tuberculosis, the definition and current management strategies. To speak to us, we have a very eminent speaker, Dr. Bandaguna Sena, Senior Consultant Respiratory Physician from National Hospital for Respiratory Diseases, Valisara. Over to you, sir.
Thank you, Ravini, for kind introduction. We'll try. This is a bit of an extensive topic. I think I will go through quickly, at least briefly, to get some idea about the new guideline, where unfortunately some of you may not have basic, at least good exposure to the current previous guideline. So therefore it may be a little difficult to follow the things pertaining to the new guideline, but anyway, I'll try to make it as clear as possible with the time I have. Now, this is the standard new grouping of the drug-resistant TB treatment drugs. We have 3 groups, A, B, and C, but from these 3 groups, group A and B are taken to have your drug regime. From group A and B, you select drugs to treat the MDR-TB patient, where the patient is resistant to INH and rifampicin. Now, if you take A and B groups, we are supposed to give at least 4 drugs to have a effective TB control in MDR-TB patients. We select a a quinolone, either moxifloxacin or levofloxacin, and bidaquilline is another drug, and linezolid. So we take 3 drugs from group A, which are bactericidal drugs, and then clofazimine, which is also bactericidal, from group B. Cycloserine is not used in the standard regimen, but if you cannot use one of these drugs from group A and clofazimine, in that case you may be using cycloserine or tericydone. Tericydone is not available in Sri Lanka. Currently we have cycloserine. With that, we have to suspect MDR-TB in patients who come to us. In our national guideline, we talk about some patients. Firstly, we talk about the people who are contacts of MDR-TB or people who were treated in the past for tuberculosis and our treatment was unsuccessful, like category 1 failure. Currently, we don't use the term category 1, but for convenience, I'm using this term. Category 1 is the standard treatment failures and also 3 treatment failures. If you have treated for the patient for the second time and still they are failing, those people are tested for MDR-TB, and also patients who had repeated treatment interruptions and previously treated people and HIV-TB patients, co-infections. These are suspected. These patients are suspected and evaluated for MDR-TB doing cultures. And also several groups are highlighted in the guideline, like children and also people who are exposed to high disease burden during their normal day-to-day living, like institutionalized patients and prisoners, drug addicts, healthcare workers, and people who are coming from abroad, and also people who are treated outside national TB program. When you come across these patients, they are subjected to sputum microscopy, and then we do a gene expert testing to look for, to identify Mycobacteria and also to look for rifampicin resistance. Once you have, if the patient is rifampicin resistant, if resistance is there, they follow one pathway, but if they are, even if their rifampicin resistance is not detected, still these patients are investigated for INH resistance by line probe assay. Currently, this is not the common practice, but with the new guideline, there's a separate chapter for INH resistant tuberculosis. So therefore, INH testing is done as a routine test, even if your gene expert is negative in high risk. Gene expert is not showing rifampicin resistance in high risk groups. But if you see the rifampicin resistance in a high risk group, you will proceed to do INH and other antibiotic sensitivity testing by gene expert. This is expert MDR XDR cartridges. That is not the standard cartridge that we use to detect RR. There's a different cartridge which will detect fluoroquinolone resistance. And if the patient is coming from a non-risk group, still if the patient has shown RR, again you will do another gene expert test to confirm that the patient is having rifampicin resistance. And if both are positive, you consider it as most likely MDR-TB, because people consider rifampicin resistant as a proxy to MDR-TB. Because people say most of the time if the RR is there, likely the patient has H resistance also. We do quinolone resistance, and also WHO recommends to upgrade our laboratories to do other second line drugs like linezolid and also INH and dilaminid and bidaquilline. Currently, we don't have the facilities to do these antibiotic sensitivity molecular diagnostics, but it's recommended by WHO because we are using new regimes. Once we know there's there's drug resistance, then you are supposed to check for quinolone resistance. I will explain why. Because quinolone resistance, if it is detected, we may have to look for high level and low level resistance depending, because some situations you may have to use high dose moxifloxacin if the patient has low level resistance against quinolone. But if the patient has proven quinolone resistance with MDR-TB, then you consider it as a pre-XDR, but with resistance to quinolone plus another one drug from group A like bedaquiline or linezolid, then the patient fall into the category of XDR-TB, where the patient will be going for a different regime. So you will realize that now in this situation, the WHO new recommendation is to do the full spectrum of antibiotic sensitivity before embarking on MDR-TB treatment. What we are doing now is we detect MDR-TB and treat. But since we are dealing with very fewer number of drugs, halfway through, if we realize the patient is resistant to fluoroquinolone or patient is resistant to another 2-3 second-line drugs, then we are in deep trouble because we don't have any drugs. Because of the new molecular diagnostic techniques, it's recommended to go through the whole spectrum of antibiotic sensitivity testing to detect H resistance and quinolone resistance and bedaquiline and linezolid resistance. But I don't know how quickly we can establish these things, but these are the recommendations. And out of the test, people say the line probe assay is more sensitive, but currently the cartridges are coming with Gene Expert, and which is much more easily performed compared to line probe assay, as you have, which was highlighted by Dr. Dhammika in the previous lecture. So I think for a while, until the facilities are available, we have to stick to Gene Expert, and the WHO recommendation also to stick to Gene Expert molecular diagnostics to get the antibiotic sensitivity of these drugs. So what are again, to recap what we have been changing from current practice, when the patient is expert RR positive, need to do the LPA to look for INH resistance. When you do INH resistance, you will be looking for CAT-G mutation or INH-A mutation. Why CAT-G? The CAT-G indicates that if CAT-G is positive, you cannot use higher doses of INH. I'll tell you in the next few slides. We are in our shorter regime for MDR-TB, we are using high dose INH. But if the patient is, from the beginning, if the patient is having CAT-G mutation for INH resistance, you may not use high dose INH because it's not going to be effective. And if you detect H resistance, again, INH resistant patients are supposed to go through testing for fluoroquinolone resistance, because if you use INH, if you are treating INH resistance, you may be using quinolone as one of the key drugs to treat this infection. And if the patient is quinolone resistant, then again you will fall into trouble. Now, when we have detected H resistance, we may have to look for quinolone resistance before treating these patients. And if quinolone resistance is also detected, then problem comes whether if the patient is detected having quinolone resistant, that means the patient is having pre-XDR TB. So MDR-TB plus quinolone resistance is pre-XDR, where you may have to look for bedaquiline and linezolid resistance. If that is there, or clofazimine resistance, then it will become a XDR-TB patient. Right. So by definition, pre-XDR is a Mycobacterium tuberculosis strain that fulfill the definition of MDR-TB and which are also resistant to quinolone. And XDR-TB is Mycobacterium tuberculosis strain fulfill definition for MDR-TB and which is also resistant to quinolone and at least one additional group A drug. So either bedaquiline or linezolid. Sorry, clofazimine does not come there, either linezolid or bedaquiline. And then These are the diagnostic tools, Expert MDP RIF, which Dr. Dhammika Vidhanagama described in detail, and Ultra. Ultra is used mainly for children because your samples are small and your bacilli are in smaller numbers, so extrapulmonary TB cases and TB HIV patients. We'll be doing rapid molecular diagnostic tests for first line and second line drugs. In line probe assay, if you are doing for first line drugs, generally we do it for sputum positive patients. Sputum negative patients, sputum we don't use to do line probe assay, but we culture, and from the culture isolated you can do line probe assay. But if you come to second line drug testing for with line probe assay, regardless of smear status, you can do line probe assay to look for quinolone and amikacin resistance. And XDR expert will detect fluoroquinolone, ethionamide, amikacin, INH for the time being, but they recommend the development of the capacity building for doing bedaquiline, linezolid, delamanid, and other tests to look for drug resistance. Genes that they detect for isoniazid, CATG and INHA, and also ethionamide and INH is again INHA gene. Rifampicin is well-known RPOB gene, which is detected in the gene expert machine, and quinolone is gyrase A and gyrase B. And then we have regimes. A longer regime, if you take as the basis, but we are using the shorter regime that is given for 6 to 9 months. As I described to you, it's about 4 drugs. And during the continuation phase or second phase, you will be using 3 drugs. And shorter regime with high dose INH, we are using for 9 to 12 months. If the patient becomes sputum convert, if the patient sputum converts very early phase of within first month of treatment, your treatment will end by 9 months. But if the sputum conversion is delayed, it may go up to 12 months. And the longer regime is the one which I described already. We are giving for about 18 months, maybe up to 20 months. And if the patient is having pre-XDR, like patient is quinolone resistant, but patient is bedaquiline sensitive and linezolid sensitive, there you can use BPAL regime, which is another shorter regime for 6 to 9 months. But it is currently WHO recommended as operational research rather than it's not still included into standard regimes of any country. But you can use this regime depending on the patient's acceptance and the available facilities. Shorter regime will include 3 main drugs: bedaquiline from group A, 2 drugs, bedaquiline and levofloxacin, and you have clofazimine. Those are the standard anti-TB drugs that we use. And then another second line drug, ethionamide, is included with other 3 drugs which are used in the first line treatment. So without rifampicin, you have 3 other drugs with high dose INH and also 4 drugs from this second line regime without linezolid. Instead, you are using ethionamide. After 6 months of bedaquiline, you stop bedaquiline and then you change over and you stop INH and you will be using pyrazinamide and ethambutol and levofloxacin and clofazimine for the balance of 5 months. That is short regime. And there are several inclusion criteria for the short regime. I will brief you on that. Now, you have certain exclusion criteria for shorter regime. Shorter regime is convenient and it's effective. We had discussions with WHO and we were not happy with the short regime initially, but we found that our previous shorter regime also have done reasonably well with our patients. That time we were not using bedaquiline, we were using aminoglycosides in the shorter regime, but it was reasonably successful. Now we are going for all oral short regime where we are having bedaquiline and this regime. But if the patient was exposed to one of these drugs more than 1 month in the previous treatment, and patient has known resistance to fluoroquinolone and resistance and effectiveness is questioned, and also patient had hypersensitivity, or on those case-by-case basis, we will be sometime deciding to put the patient not on shorter regime, but to go for a longer regime. And also, these children under 6 years where you cannot use bedaquiline, and patient with advanced disease like bilateral parenchymal disease, bilateral chest involvement, and also patients have extensive extrapulmonary disease like miliary TB, disseminated TB, meningitis, that kind of patients. HIV patients with extrapulmonary disease, and also if there's severe renal and liver involvement, liver derangements, and also patients with prolonged QT intervals, where bedaquiline can cause prolongation of QT interval. These kind of patients, and also in pregnant women, the short regime is not used. And then this is the standard longer regime that we use. I have already discussed bedaquiline. There are 3 drugs coming from group A and 1 from group B. Then if the patient has quinolone resistance, you may be using BPAL regime, where you will be using bedaquiline, pretaminid, and linezolid for 6 to 9 months, or even up to 1 year. Right. Now, if you cannot use this group A and group B drugs, then you have another spectrum of group C drugs. Supposing this cycloserine is the next choice. If you cannot use get 4 drugs from the standard group A and clofazimine, then the next choice is cycloserine. If you cannot use these drugs, if you cannot get 4 drugs from those combination, then you have to go to group C, where there are options given. Cycloserine, after cycloserine, people they recommend ethianamide, delamanid, and amikacin, depending on they consider they are more effective compared to the other drugs. But in these regimes, you have meropenem, imipenem, cilastatin, and paraaminosalicylate acid, and those drugs also. Bedaquiline is not given for children less than 6 years, and delamanid can be used between 3 to 5 years of age. In children, so therefore, if the patient has quinolone resistance, you can use cycloserine instead. And if the patient has if the quinolone sensitivity is there in a younger child, you cannot use bedaquiline, but instead you are using cycloserine. But if the child has quinolone resistance as well, then you may have to go for pyrazinamide, and ethianamide is added. 3 to 5 years, if the quinolone susceptible child can be given the same regime as a younger child, but if there's quinolone resistance, instead of finding these things, you can use delamanid and ethianamide and these drugs. Pregnancy standard treatment is given. Linezolid is not given, and instead cycloserine and pyrazinamide is added in the regime. It's relatively safe. Clofazimine is relatively safe in pregnant mothers. Standard recommendation for INH resistance is 6 months of first line drugs plus levofloxacin, where that's why they recommend to do quinolone resistance right at the beginning of starting treatment for INH resistant people. Then outcome of the disease treatment is similar to standard anti-TB treatment treated patients. But the definition of cure is generally we take about 4 cultures being negative over 2 months or over 3 months. Because at the beginning we will be doing once a month 2 cultures, but later on we may be doing every once in 2 months. Whatever it is, if you have 4 consecutive culture positives and if you have completed your treatment, you can consider it as a cure. But if the patients start becoming positive halfway through on treatment, you may extend the duration of treatment depending individually, deciding on individual basis. There's no real bacteriological clearance is called cure, but when you document a patient as cure is a bit of a question in your region because people don't have much experience with the current regimes. Basically, I think that's all I have to tell you about the current. It's a vast thing. There are so many facets of this treatment, but this 25 minutes lecture is not enough to talk, and I am also not very thorough in this subject because I am also learning and reading. But within my capacity, I would wish to answer any questions if you have any doubts.
In this currently evolving scenario, are there concerns that these medication, I think they are coming from the Green Light Committee, so we should be okay. Is there any concerns that this we may run out of these medications?
Currently, our first-line drugs that the World Bank will not give. Yeah, they are not going to give any further. But regarding drug-resistant TB, still they are maintaining. That's right. So then, global drug facility and pre-qualified drugs we will be getting. That's the situation currently.
Thank you. Sorry, thank you, Bandhu for simplifying this very complex talk. Please accept a certificate of appreciation. Next, we'll move on to the next topic, which is CNS tuberculosis, the controversies and the way forward. Let me please invite Dr. Amita Fernando, Senior Consultant Respiratory Physician, National Hospital of Sri Lanka. Over to you, sir.
Thank you, Ravini, for that kind introduction. Looks like Dr. Bandhu has stepped down, so I salute you. Since I haven't not familiar with that heights and I'm a common man, I will step up. So in the next few minutes, I plan to talk a little bit upon the new challenges that we are facing on CNS TB. I'll focus my talk mainly on central nervous system involvement. I'll touch briefly on spinal TB. As our team knows, we have been seeing a spate of CNS TB referrals over the past couple of weeks. Diagnosed patients and patients who have complications due to CNS TB we have been seeing. So it means that there is active pulmonary TB in the community, and the number of CNS TB patients are a reflection on the number of active open pulmonary TB cases in the community. And we are going to face future challenges. We were unable to give you a snapshot, but I think we are going of TB, but we are going to face challenges with current poorly controlled comorbidities and malnutrition and other challenges. We have to safeguard the BCG. So many other challenges that we as a society will have to face in the months and years to come. So CNS TB accounts for 1% of all TB, 6% of EPTB. In miliary TB, 20% have CNS involvement, as we know. CNS TB includes TB meningitis, tuberculosis, and spinal TB. TB meningitis without tuberculosis accounts for 75% of CNS TB. Tuberculosis alone accounts for the rest of the 25%. TB meningitis is a medical emergency. It carries high mortality of 50 to 40%. 25% of patients with TB meningitis will end up with permanent neurological deficits. I'll just have one case to illustrate my talk. This is of a 28-year-old female, a history of prolonged febrile illness and headache of 1 month, acute worsening of headaches with altered level of consciousness, no fits, weakness or numbness, no cranial nerve palsies, no contact or past history of tuberculosis. Just a summary of in the investigation, you don't have to go through this. If you may note, pre-treatment liver functions remained elevated in this patient, and the albumin was a little bit low, alk phos was high. This is the CSF report, which showed a protein of 194 milligrams per deciliter, sugar of 7 milligrams per deciliter. The RBS was 105 milligrams per deciliter, so it was 15%, less than 50%, which is quite low. Total WBC-DC was 15, neutrophils of 2% and lymphocytes of 98%. Acid-fast bacilli staining was nil. ADA was 10. That I have incorporated for studies, for learning purposes. But there are neurologists who prefer to do ADA and who do ADA in patients with adenosine deaminase in patients with CSF TB. Cytology showed no atypical cells. On the other side is the normal appearance. It's important document appearance as in pleural fluid of CSF also. 80 to 90% the appearance is clear. Opening pressures are high. We do not do opening pressures here routinely, but in some countries they do measure opening pressures. The total WBC-DC count can range from 5 to 1,000. Neutrophils in the early phase in some patients, 10 to 70% of patients, and in those who are immunosuppressed and those who have immune deficiencies. Lymphocytes is the predominant cells. When we get referrals most of the time, about 30 to 90% are lymphocytes. Proteins are high, and it can be very high if there are spinal blocks. Again, the units, we have to have uniformity in units. Some units are, some reports we get at 100 in milligrams per deciliter, grams per deciliter. Same thing we had with pleural TB, where we get, the units are not uniform. So these are issues that we need to discuss with our colleagues in chemical pathology to have uniformity in these units, so that it makes interpretation for busy clinicians who are not very numerically enlightened to make interpretation easy. So a little bit about ADA. As we know, and as we discussed in the morning, adenosine deaminase is useful in pleural TB, pericardial TB, and peritoneal TB sometimes. But in CNS TB, it's quite different, because ADA can be elevated in CSF in TB meningitis, but unlike in pleural fluid, the lymphocytes are not that very numerous. The burden of lymphocytes in the pleural fluid is not very numerous. Furthermore, 50% of these lymphocytes perish in vivo, in vitro, within 1 hour. So if you are processing and looking for adenosine deaminase in these patients, the fluid should be analyzed within 1 hour. And unlike in pleural fluid, where we have a gold standard comparator in pleural biopsy, histology, and culture, in CNS TB, we don't have a gold standard like a histology or culture, where sensitivity in these paucibacillary forms are low. So ADA, though may be useful as a rule-in or rule-out condition, has not been very well established in CNS TB. And for other conditions like CNS lymphomas, malaria, brucellosis, even in pyogenic meningitis, ADA can be high. ADA can be falsely positively high in pyogenic meningitis. To differentiate pyogenic meningitis from TB meningitis, it is not useful. Interferon gamma assays, you heard a lot about interferon gamma assays and the types of interferon gamma assays in latent TB and other forms of TB. But as mentioned by Dr. Shanta, its role is mainly in the diagnosis of latent TB, and it's not recommended as a diagnostic tool for active TB. And again, because it's dependent on the lymphocyte burden, the antigenic stimulation is dependent on lymphocyte burden. Because in paucibacillary forms, it may be of little clinical utility. Acid-fast staining, studies have shown, and some of these data I have taken from our own latent TB guideline, which was done, our extrapulmonary TB guideline, which was done some time back, and I have contributed to these chapters. So I don't feel bad about copying it. Right, so the laboratory protocols, At least if you say that some studies of direct staining of acid-fast bacilli is quite volume dependent. They say a minimum of 6 ml of CSF should be sent purely for microbiology, where it has to be centrifuged at 3000 revolutions for 20 minutes, and the slide should be prepared with a 2-drop method, as we are doing for acid-fast staining of sputum, to achieve a significant positivity rate. So this kind of CSF volumes purely for microbiology we rarely send. So the 6 ml of CSF is rarely sent. And they say that not only volume but repeated examination of CSF, say like you are doing 3 sputums, repeated examination of CSF may increase the sensitivity. So there is some studies saying that it may be as much as 80%. So that's why I asked Dr. Dhammika in the morning when we are doing Gene Expert and Ultra in this patient, whether it would increase the sensitivity of doing that in centrifuge specimens. So TB culture, you heard a lot about TB culture, liquid cultures and their utility. So this, as you know, are retrospective. The TB meningitis is a medical emergency, and we need to act on clinical grounds and other available evidence, so we can't wait for culture. But as you know, culture is important to know about drug susceptibility, and because certain chemotherapeutic agents like rifampicin are not very good CSF penetrants, and in instances where there is rifampicin resistance, this may provide usual guidance. So you heard about nucleic acid amplification test. I was looking at the Cochrane database, and this is what they say about Gene Expert Ultra, Gene Expert and Gene Expert Ultra. We had the facility at NHSL, but unfortunately, we have run short of cartridges at the moment. I don't know how that calamity happened. Whether there was issues with planning, stock taking and things, how it happened, we don't know. We have ordered the National Program for Tuberculosis Control and Chest Diseases, have provided MLT to do this service, but at the moment it was running smoothly, and we were doing about a lot of things, especially in CSF TB, but now we are out of it. We have outsourced sputum AFB at the National Hospital of Sri Lanka to the Faculty of Medicine, Colombo. So that's heartening, right? We have about 500 people. Our fellows are holding their heads. No, president is getting... These are truths, no? We have to face those, right? Right? I won't embarrass you, madam. Right. Yes, so we detect about 500 patients with smear positive with pulmonary and extrapulmonary forms of TB at the National Hospital. And the gateway is the OPD, where these patients are probably missed at the OPD, but unfortunately, after 10-year struggle or plus struggle, we are still unable to establish sputum smear microscopy outpatient facilities. Right. So yes, so Gene Expert and Gene Expert Ultra, as we know, are useful tests. Sensitivities range from 90%, even a little higher in Gene Expert Ultra. As Dr. Dhammika Vidanagama told in the morning, caution should be exercised because Gene Expert Ultra looks at 2 genetic domains. The IS 1610 in Gene Expert and the other domain, which is very sensitive, and sometimes false positive rifampicin resistance have been detected in these patients. So we must take this in clinical context, but Gene Expert Ultra and Gene Expert will be useful tools in diagnosing a condition like CNS TB, which carries such a high mortality. Again, as we know, the MAN2 test or the tuberculin test, highly variable, 10 to 50% of CNS TB may be positive. As you know, in miliary and disseminated forms of TB, it can be negative. This is the chest radiograph of the patient we started our story with. So the patient had miliary mottling, costopharyngeal angles paired of miliary TB. So 10% of CNS TB patients have miliary TB, and 20% of patients with a miliary TB have CNS involvement. So it's very important in CNS TB patients to do a chest X-ray, a chest radiograph, because there may be miliary TB, there may be evidence of healed or past history of TB or active TB in the form of granuloma, fibrosis, and scarring. Sometimes when we get referrals for a complication of anti-TB treatment, In patients who have drug-induced hepatitis, for instance, we find that the chest radiograph hasn't been done. So when we do the radiograph, we do in some instances find evidence of pulmonary involvement in such patients. The role of CT brain is useful, and it must be emphasized that we shouldn't wait if there is a delay in imaging. If we have our clinical parameters, if your CSF sugar is low, lymphocytosis, clinical things suggest TB, we shouldn't start treatment pending imaging. CT has a role to play. Common cerebral TB features are of basal contrast enhancing exudates. Features are seen in 40% of adults, 80% of children, and may be absent in the elderly. Infarcts as a result of vasculitis, periarteritis, basal meningitis, or tuberculomas are found in 20% of the patients at presentation. This is important so that this periarteritis and vasculitis can give rise to infarction and causes permanent neurological deficit and even maybe life-threatening. More than 70% develop tuberculoma during treatment. There can be paradoxical reactions, worsening reactions. Sometimes such patients are referred to us. In such instances, we may do a repeated lumbar puncture. And I feel that if the reaction is a paradoxical reaction, in such instances, the CSF sugar will not be low because it's an immune-mediated reaction. And this may help us to distinguish a paradoxical reaction from a worsening clinical scenario. Infants, as Dr. Idma emphasized, CNS TB can be catastrophic. It can cause basal ganglia involvement and involvement of striatal and other important cerebral arteries. A combination of hydrocephalus, basal enhancements, and infarction are sensitive for diagnosing TB meningitis. Pre-contrast hyperdensities in the basal cisterns suggest TB as a strong possibility because in other pyogenic meningitis, it's more on the surface of the brain, whereas in TB, it's more basal. The MRI brain provides high definition, a more detailed view of the infratentorial regions and early cerebral changes of TB meningitis. But as we know, many things may mimic this ring enhancing these lesions, like cryptococcal meningitis, toxoplasmosis, sarcoidosis, in which case the sugars will be normal. Meningeal mets, lymphomas can produce similar MRI signs. Treatment, as I emphasized, must not be delayed till imaging is available. So this is the CT MRI scan of our patient whom we started off with. Showed acute infarcts, early obstructive hydrocephalus with dilatation of the third ventricle, mild edema noted with could be due to basal meningitis. So the likely radiological diagnosis was of TB meningitis. A little bit on tuberculomas. So tuberculomas are interesting features. It is basically it's organized granuloma. There are several stages of tuberculomas. We learned that when we have MDT discussions with neuroradiology SRs. So having specialized neuroradiologists, as we should have chest, has increased the knowledge in these areas and about the clinical utility of these things. So tuberculomas can be very organized, fibrotic ones. They can be in various stages where there's liquefaction in the center with a ring enhancement. So the liquefying center in the middle contains caseous material, a rich source for Mycobacteria to remain, and this acidic media will be only reached by drugs like pyrazinamide. This may be a focus of releasing Mycobacteria into the CSF in patients whom we see poor response to treatment or delay in responding to treatment. And when we talk about therapeutics, we talk about the role of pyrazinamide in these patients. So it's important to have multidisciplinary discussion so that we share our knowledge with each other, and we also impart knowledge, and we are able to sort out many of the issues that confronts our patients. MR spectroscopy, where we used to do that in tuberculomas, usually single lesions. Sometimes the neurosurgeons do this to differentiate gliomas from other metabolically active infective lesions. They have said that there is some evidence to say that MR spectroscopy may show a high lipid peak in a metabolically active infective process like a tuberculoma, but whether this is convincing and whether this is evidence enough, I couldn't find any details on that. So we started our patient on weight-adjusted anti-TB treatment, IV dexamethasone. As we know, there can be periarteritis, inflammation, edema around the tuberculomas, giving rise to infarcts and things, so it's important that you have your steroid on board. The patient to start with had deranged liver function with elevated alkaline phosphatase. So we had a dilemma whether we should start first-line anti-TB drugs, whether it's safe, whether it could worsen the liver conditions. In our experience, we have seen that in patients with miliary TB who have 50% have liver involvement, and liver biopsies are a good diagnostic site yield, they pre-treatment also they have elevated liver functions with gamma GT and alkaline phosphatase. So could this be part of disseminated TB? Is anti-TB starting first-line anti-TB? Could it worsen transaminitis? We were concerned if we start this patient on bridging regime, our options were ethambutol, levofloxacin, and streptomycin. You know that streptomycin and ethambutol are not very good CSF penetrants, and then we would be left with levofloxacin alone. And in regimes that included levofloxacin hasn't been shown to have a mortality benefit in patients with CNS TB. So if we are going to bridge this patient, what bridging regime would we select was another issue. The sugar was quite low in this patient, as you saw, less than 15%. So probably the patient has a high bacillary load, though we were unable to do the gene expert to the current in this patient due to current constraints. So this is the chemotherapy regime. I just wish to highlight one or two points. The CNS TB treatment regimes are based on pulmonary TB regimes, the same drug regimes, same dose regimes. Whether this is appropriate is something that we should look into. Because drugs like rifampicin, INH has good CSF penetrance. Drugs like rifampicin penetrate the CSF less well. Maximum concentration is 30% of that in plasma. So a 10 milligram dose of milligram per kilogram dose of rifampicin, whether it's adequate is a question. Whether we should go for a higher 15 or even 20 kilograms of body weight dose when it comes to rifampicin is something that the technical support group established by us with a lot of pressure on the National Program of Tuberculosis Control with other stakeholders should take into account. And again, I couldn't find any literature on the how effective fixed dose formulations are in crossing the blood CSF barrier. Because these drugs in combination, as opposed to individual drugs, whether it works as well and whether being in a fixed dose combination has any impact on the CSF levels is a question. We have had many MDTs with our senior registrars, and our teams have had many discussions with Dr. Bimsara and his team, and Dr. Bimsara in particular, about these regimes, and we have opted to go for individual drugs in patients with CNS TB because we are not sure of how safe, how effective the fixed dose formulations are. So pyrazinamide, as I said, is well absorbed orally and penetrates the CSF well, achieving high concentration. It is the only anti-TB treatment drug that acts in caseous acidic environment of tuberculomas. It's argued, and there is no evidence, but there is some evidence that pyrazinamide should be continued for the full 18 months of treatment, especially in cases where tuberculomas, I must say that CNS TB we treat for 1 year, but if there's tuberculomas, we will treat them for 18 months. Right, so the fourth drug has been streptomycin and ethambutol, in addition to the first INH, rifampicin, and pyrazinamide. Ethambutol, we'll have to stay with ethambutol because now WHO is opting out of streptomycin as a first-line agent for TB in anti-TB regimes, and the availability of streptomycin, quality-assured streptomycin, won't be there through the global drug facility. So we have to go outside to buy that, and we can't have guarantees on quality assurance of the streptomycin. So I think streptomycin will be gradually move out of anti-TB regimes. The fluoroquinolones, as spoken, and Dr. Bandhu emphasized this, it is second-line anti-TB drugs, and we are, as physicians, are a bit cautious about the quinolones because we need them for our patients with MDR and other drug-resistant forms of TB. Penetrate the CSF well, but the role in reducing mortality is not well documented. It should be avoided in pregnant mothers, breastfeeding, or in young children with growing bones. The role of adjuvant steroids is very important to emphasize. We give steroids for the very reasons, like I said before, periarthritis, basal meningitis, because I have seen patients who have infarcted, massively infarcted, because the steroid was not given, or because some astrologers told it's a bad period, don't take any of this medication. You'll be only, they will only work after 2 weeks. And I have seen a child who infarcted half of the brain. මේ දවස්වල සාත්‍රයක් අහන්නවත් යන්න දෙන්නේ කාටවත්. සාත්‍රයක් අහන්නේ සාමාන්‍ය මනුෂ්‍ය අයිතිවාසිකමක් නේද? So equivalent dose of dexamethasone can be given. Dexa may be preferred due to its anti-inflammatory properties. Steroids are given in reducing course. You must realize that when giving rifampicin, we opt for a higher dose of steroids because of drug interactions. In patients with tuberculomas or those who are resistant tuberculomas or not responding to high-dose steroid, this is often, we have encountered this where we get referrals. Right, so they have tuberculomas developing maybe a paradoxical reaction. CSF sugar is low, protein sugar is normal, protein is high. The steroids are not working. What are we going to do? So in such instances, if you are on adequate steroid dose and adequate regime of anti-TB, we haven't so far given that, but we may have on an MDT discussion consider such agents. So the role of repeated lumbar puncture. I think some of these patients, when they get referred to chest clinic and they are on anti-TB treatment, they default or do not go for their neurologic visits. So they will think that now the patient is with us, and sometimes we see with the patient on the initial visit and they are followed up by medical officers. Unless a problem arises, they will not bring the patient to us unless there's drug-induced hepatitis or such a problem. But we with Dr. Bimsar and his SR Sudat, who is now overseas, followed up this patient, and we felt that this patient we should do a LP at 1 month, and then like doing sputums at 3 months, whether we should assess this patient with a follow-up lumbar puncture. If we are doing so, different biochemical parameters change at different times. Glucose normalizes faster than WBC-DC. Studies looking at lymphocytes alone. So the first thing to normalize is your glucose. Protein may remain high, but it will normalize if the patient is adequately responding. Studies have looked at lymphocytes. Studies have looked at the total white cell count, not lymphocytes and neutrophils in isolation. This may take a little longer than the protein and glucose to normalize. So the PCR or the genetic assays, because genetic material of dead bacilli may persist, may remain positive even for months, even in a clinically responding patients. So PCR is not a good guide, or your gene expert and your ultra is not a good guide in monitoring clinical response. Drug-induced hepatitis, as we said, is a problem in this group of patients. So when these patients have drug-induced hepatitis, either prior or during treatment, what we have to do is we have to go for a bridging regime, which would be streptomycin, ethambutol, and levofloxacin with the currently available medication. So as we know, levofloxacin will be a single drug in these patients with high bacillary loads, poorly responding tuberculomas. So we are concerned whether we should use levofloxacin alone in these patients. So we can wait for a higher threshold. We can wait for the liver enzymes to go up to 5 times normal, not 3 times the upper limit of normal. We can continue INH and rifampicin and withhold pyrazinamide. We should monitor the patients carefully, looking at albumin levels, rising transaminases, and prothrombin times to see whether the patient is developing complications. In instances where we have to stop the INH and rifampicin also as well, I have been looking at the literature, and then as a bridging regime, linezolid and ethanamide have been used. Both have good CSF penetration, but we have to be cautious with this because these are MDR TB drugs, and a consensus decision has to be taken, and it should be a MDT decision. So moxifloxacin, levofloxacin, when we are using as bridging drugs, levo we can use as a bridging drug, but moxi and linezolid and ethanamide, if we are using, we have to exert caution. There may be indications for surgery. Hydrocephalus is the most common reason for surgical referral. Most authorities suggest that ventriculoperitoneal shunting should be considered in all patients with non-complicating hydrocephalus. Tuberculomas may coalesce and form cerebral abscesses necessitating surgery. Spinal TB, if there is features of paraparesis, is an indication for surgery. Briefly, I'll tell you about spinal TB. We do get a fair amount of spinal TB as well. Now, with Mobitrex and MRI protocols which are easily available and even cheaper than a contrast CT, spinal imaging is frequently done. Way back when we were practicing, In outstations, what we had was the lumbar, the X-ray of the spine, epilateral, looking at reduced anterior height, sclerosis, end plates being involved, paraspinal masses, psoas abscesses, and CT myelograms were look for neurological problems. But now we have the MRI. We see anterior height reduction, vertebral body edema. We see paraspinal masses. TB is more anterior. It starts in the nucleus pulposus, hematogenous spread. It's more anterior, whereas malignancies and others are posterior, and it involves the pedicles more. We have access in some instances where there are paraspinal masses, where we can do aspiration where we can do the aspiration of these paraspinal processes, and we can send them for microbiology, including the PCR assays. So surgical intervention, again, I think MDT discussions, when should the neurosurgeon or the orthopedic surgeon go in? Because as you know, if this patient develop paraparesis, young people, managing a paraparetic patient in our country is going to be a disaster with bed sores, and will have a horrible death. So it's important that these decisions are taken because it not only destroy the patient, it will destroy whole families looking after such patients. Right. Atini.
Thank you, sir. Do we have any questions for Dr. Amita Fernando? So in the absence of any questions, let me thank sir again. Thank you for giving us the practicalities of managing CNS tuberculosis. And sir, please accept our token of appreciation. I have two announcements. One is that all this program will be available for viewing on the YouTube of the Sri Lanka College of Pulmonologists. So if anybody has missed any aspect of the academic program or want to rewatch it, please go and visit the YouTube site of the Sri Lanka College of Pulmonologists. Second announcement is that we are not able to hold the talk on snapshots of tuberculosis in Sri Lanka due to unforeseen circumstances. Dr. Niranjan Desanayake is unable to be with us today. So let me apologize on behalf of the organizers and the College of Pulmonologists for that. Next, we have a very interesting segment of our academic program, the last one, which is the TB quiz. And I invite Dr. Vatsala Gunasinghe and Dr. Geeta Pera to take the podium.
Okay, so we'll start the quiz. Some of the pictures are simple, some will be informative to you, and some will be a little bit on the difficult side. I hope you will actively participate. Okay, first question, what is the diagnosis? I think those who have worked with us probably easy diagnosis. Anybody to answer?
Who is for number one? Hands up. Nobody. Number two? Or B? C? D? E? Everybody is D.
Okay, so you know it, you have seen it. I think as practicing clinicians, you must have seen this. So this is a tuberculin skin test or MARTU test, which is strongly positive and blistering. The actual MARTU test, you all know, it's a hypersensitivity reaction to tuberculous bacillus protein derivative, and it is a type 4 reaction. And positive test indicates the infection. If this ulcerates, we can apply a dry dressing and keep it. It will resolve spontaneously on most occasions. So the second question is, a 5-year-old child with a contact history of pulmonary tuberculosis presented with shown clinical features. So what is the likely underlying pathology? Post-primary TB, disseminated primary TB, disseminated streptococcus infection, cellular immune reaction to primary TB infection, sarcoidosis.
So number 1. Number 2. Sorry, B. C. D. Everybody is D. E. D.
Okay.
That's what they say.
Okay, good. This is a cellular immune reaction to the primary TB infection, where when you are exposed to TB bacillus, within 2 or 3 weeks, you have an immune response. During that initial immune response, you can have this clinical manifestations, especially seen in children. First one is the flectinular keratoconjunctivitis. So it is also not an infective thing, it's a hypersensitivity or inflammatory lesion. And also in the shins, you can see it's erythema nodosum. I think all of you are aware about the causes of erythema nodosum. So this will spontaneously go down with time. And in addition, with this initial immune reaction, they might develop serous effusions in peritoneum, pleura, and joints also. This is the third one. What is the radiological diagnosis? I think it is even visible, even if it is projected in the. I think it is fairly visible. So what do you say? Yes, it is diffuse bilateral small lung nodules. You can see multiple nodules, small nodules, diffusely distributed. So it's it can be due to many reasons, but in this case, it is a miliary tuberculosis. It is in TB. It is due to the hematogenous dissemination of infection, and it can occur as a part of the primary infection or post-primary disease. It is characterized by uniform small nodules with random distribution, and you can see in nicely in the HRCT film the randomly distributed nodules of 1 to 5 millimeter size or 1 to 4 millimeter size. It is all over, like it's over the peribronchoscopal bundles, in the centrilobular positions, as well as in the pleural surfaces. So this is the miliary nodules. But when you see miliary nodules, it will not say that it is 100% tuberculosis. You have to keep the other differential diagnosis also in your mind, like miliary metastasis, another fungal infection, and miliary sarcoidosis, and there are other causes. And when we discuss about miliary tuberculosis and meningitis, Amrita also mentioned, when you suspect miliary tuberculosis, it's like an emergency situation. You have to get the things, investigations done quickly and start anti-TB drugs as soon as possible without waiting for a long time, because then they will go into being very ill, or they might develop meningitis, so with devastating consequences. Question 4, what is the HRCT appearance? Miliary tuberculosis, stream bud appearance, peribronchovascular nodules, mosaic attenuation or consolidation with ground glass opacification. So what is the appearance? Yes. Okay, yes, it is tree in bud appearance. I think this is important for all of you who see the HRCTs, and this is a important appearance to remember and be able to recognize. So actually, in the arrowhead will show the place where the tree in bud appearance is there. You can see that there's like a branch in linear opacity of the same caliber originating from a single stalk. It is branching. The black arrowhead shows the area. So actually it represents, in case of tuberculosis, it represents endobronchial spread of tuberculosis, and or any other pathology causing filling of the terminal bronchioles, alveolar ducts and alveoli can give rise to similar appearance. Here the lower down picture shows actually what is a tree in bud in actual real life. That is you can see in spring in Western countries where in the spring how the trees bud. So that is the representation. Similar appearance is given radiologically. So there are so many causes of tree in bud pattern. It is not only tuberculosis. It can be TB. It can be other mycobacteria other than tuberculosis, and fungal infections, and like cystic fibrosis where there's very thick secretions clogging, and also panbronchiolitis, and also immunological disorders. So there are a lot of reasons that you can see this, but commonly in Sri Lankan situation, when we see this kind of appearance in the HRCT, we always think about tuberculosis also. So what is the next question? What is the likely pathology for ultrasound images? It's a loculated pleural effusion. This is an easy one. Polycystic kidney, matted lymph node of tuberculosis, or pseudoaneurysm due to tuberculosis, or salivary gland enlargement. For the interest of time, I will just mention it is the matted lymph nodes of tuberculosis. This is for you to just know how they look ultrasound through the ultrasound. Here in the top pictures, you can see the hypoechoic lymph nodes with some heterogeneity inside, and also they are joined together and matted. In the lower down first picture, it's not vascular. These lymph nodes are not vascular, and this is the last one shows after treatment when they are resolving. Next question. This patient with active pulmonary tuberculosis presented with massive hemoptysis. What is the likely cause? Aspergilloma, Rasmussen aneurysm, bronchiectasis, pulmonary hemorrhage, or melioidosis. Can you compare the non-contrast and contrast images? If you compare them, you can see that there's a contrast enhancing and vascular-like structure inside that cavity. Okay, it's not just not like a fungal ball. In addition to that non-enhancing irrigation, there's a vascular-like contrast-filling area also. So this is actually what is called a Rasmussen's aneurysm. By definition, it's a rare condition, but it is important for you to know about it. It's a pulmonary artery aneurysm adjacent to or within the cavity of tuberculosis, and it is caused because of the gradual weakening of adjacent pulmonary arterial wall because of the ongoing inflammation. And the granulation tissue replaces the adventitia and media, and then becomes fibrotic, and then it develops into a pseudoaneurysm. So this can cause a massive hemoptysis, especially in our context. I think we send patients for repeated bronchial artery embolization, and sometimes they don't settle. So we have to always think about it, and CTPA will be useful to diagnose these conditions better. This is the easy one. What is the shown in the biopsy of the lung? This is for the, yeah, it is obviously, it's a granuloma. You can see, I just wanted to, all of you to remember how the granuloma looks like. We have studied them when we are like undergraduates. So in the granuloma, the special features are like for the TB, it's typically caseous with the caseous granulomatous necrosis. So the inside pink material is the caseous material, and in addition, you can see the Langhans giant cells and also epithelioid cells, and also there's a surrounding rounded cuff of lymphocytes. So that is the usual appearance of a granuloma. So we have some more pictures coming up. Just wait.
Yeah, you guys want to come down? Change your mind? You could see this? Good. Just a few. Just TV quiz ke liye tarak daal.
TB quiz.
That's why I wanted you all to come down, because now there won't be holes or anything like that with me. This patient had a community-acquired Klebsiella pneumonia. This is the X-ray. What do you think about this? Is this TB? Can this be TB? It's a squamous cell carcinoma in a patient who has had TB long time ago. So one thing that we don't want our registrars to do is to discount other lung diseases for TB, because Apollo lesions are not always TB. There can be other conditions as well, and those are fluid-filled cavities. Of course, Klebsiella pneumonia, Klebsiella can be there, but that doesn't mean that this is just a simple past TB bronchiectasis. There can be other things also, so keep looking for them. A 24-year-old girl with weight loss and cough. What do you think this is? Miliary TB? Obviously, the two of us had not been talking to each other for the last whatever. It's actually, if you look at these, I mean, anybody can say that it's miliary TB, but most of these nodules are gravity dependent. Can be miliary carcinomatosis. That's a girl with a thyroid cancer who had developed that, of course, when you're 24 and having a cough and a fever, or without a fever even, you tend to diagnose TB, but there can be other things as well. So be careful. Those nodules are miliary nodules, all right, but you see it's predominantly down there. And you know secondaries tend to be lower down. Now you get these demented ladies who are brought in by their grandchildren or great-grandchildren because they want to go for a trip. And if they find this thing, have a cough or something like that, you want to do something, you see this. What is this? Upper lobe lesion. Obviously the lady can't remember. That's why I wanted you all to come down. Secondaries? Once upon a time when the anti-TB was not there, there was a treatment modality called plombage, where the lobes were collapsed by inserting plastic balls or glass balls or something like that. And when the lung collapses, the aeration goes down, and as you know, mycobacteria are aerobic bacteria, and then it helps to recover. So in this one, you see the calcified lymph nodes here, plus these rounded, very rounded, non-biological walls, lesions. Of course, all of these things are stolen from different places. What is abnormal here? Pericarditis, pain down left arm, TB? Not really. I've seen this also. This is not the typical thing, but these are Pancoast tumors. Pancoast tumors can be passed as TB, and then, as you know, what happens is you are given anti-TB because you think that you know it, and then put them on anti-TB like as smear negative TB, and the patient suffers for another 2 months until this starts coming down. The X-ray is done 2 months after, so be careful not to call everything that happens here as TB. And we are shifting from the radiology side. Now, if you look at this, what are these? This is a 5-month-old baby. Generally, these are staph infections, aren't they? Until you look at the BCG scar, which is ulcerated. These the disseminated TB. In this case, BCG, disseminated BCG can come like this, especially when the children have immunodeficiency, which is not diagnosed at this age. This kid looks quite okay. He's not thin or wasted or anything like that, but common variable immune deficiency can be there. So look at the BCG scar also when you get a kid with something abnormal. In HIV patients, you can have the same thing happening with Mycobacterium tuberculosis because of the immune issues. Now, did I give the diagnosis out? This is the chest. So, extrapulmonary tuberculosis causes cutaneous. This is cutaneous TB due to dissemination on blood. So, if somebody is immunosuppressed and they have an odd rash, think about TB also. It's not always TB; it can be anything else, but Kaposi's or whatever you want to call it. But remember this also. So, you need to do a biopsy, not give something to apply. And this is the posterior surface of the leg. Two different images. What it is? It's called Bézine's disease. It's a type of erythema nodosum, erythema induratum. It's not erythema nodosum. Erythema nodosum happens at the anterior aspect of the shin. This is erythema induratum. It's a type of immune reaction to TB. Now, when you have pulmonary TB, sometimes this, due to the antigens that get released into the blood, you can have this kind of a manifestation, especially in the legs, especially in females. It's a type 3 and 4 immune reaction. You can detect DNA here. PCRs could be positive, but but that's because it's the mycobacterial antigens that come, but they're not live bacilli. So it's basins. You got to treat the disease rather than treat this. So if somebody presents with a lesion like that, think of doing a chest X-ray as well. Looks quite common, isn't it? Like, say, let's make up a story. Like, this is a kid who was brought in for screening because the grandmother had TB. And this kid had, let's say, cough and eczema, asthma and eczema. And you see this. You assume that this is eczema reaction due to the ear, whatever, nickel or something like that. Not necessarily, it's lupus vulgaris. So these things can be there. So you got to look at the whole patient as a whole if you are going to eliminate TB or manage this thing, because now we are coming to a stage where we can kind of go for elimination at some stage. So it's important to look and suspect TB all the time. That's why I use some of these slides just to keep it interesting. Thank you.
Okay, I think that, I will invite Dr. Ravini Seha back to the podium.
Dr. Geeta Pera and Dr. Vatsala Gunasinghe for providing us with a very entertaining quiz. Ladies and gentlemen, we have come to the end of our session. I think it was a very productive morning with a few mishaps here and there. So let me invite you once again to visit us on our YouTube channel to see this recordings of this program, and also to visit the Sri Lanka College of Pulmonologists website for future events. Let me thank the organizers of this program, which is actually the leadership was given through the Mycobacterium tuberculosis Assembly of the Sri Lanka College of Pulmonologists, headed by Dr. Geetal, Dr. Ishant Perera, and Dr. Vatsala Gunasinghe. Let me also thank all the speakers for coming out during these difficult times and spending time with us. Let me thank the sponsors of this meeting, Lina and Cadilla, for sponsoring this, and also all of you for being here with us, both the physical and the virtual audience. So we look forward to meeting you once again with our upcoming events on World Asthma Day. Thank you very much.